அந்த ரூம்ல இருக்காரு. அந்த கதவு திறந்து வச்சு. Good evening to one and all of you for this PG update series on refractive surgeries. And to run the show, teach you and iron out your queries, we have the very best of expert channel. And we are lucky to have with us our president of AIOS, Dr. Mahipal Sachdev, who will be joining us shortly. Our past president, Dr. Ramurthy, our honorary secretary, Dr. Namrata Sharma, Dr. Rohit Shetty, Vice Chairman of Narayan Netralia Group of Hospitals, Dr. Sri Ganesh, Chairman and MD of Netradama Group of Hospitals, Dr. Anaga, who is the Managing Director of Anil Eye Hospital, Mumbai, and member ARC West, would join me to moderate this session. So there is a small change in the sequence of talk. Dr. Krishna Prasad Kudlu needs to travel to Goa, so we shall keep him as our first speaker. So we are here to introduce to you a hero from Udupi, a very dynamic, efficient leader with political leanings too, and also the MD of Prasad Netralia and member scientific committee AIRS, who is going to talk on a new frontier, presbyopic LASIK, a fairly untouched frontier as yet. On to you, Dr. Kudlu. Could you share your screen? Dr. Krishna Prasad?
Yeah, can you see my slide, madam?
Yes, yes.
Yeah. Once again, thank you so much, Chitra madam, for this wonderful opportunity. What a feeling to be in between the ERC panel. The first time I think I'm coming inside the ERC. I'm very much thankful to you, madam. So I'll be talking about the presbyopic LASIK, a new frontier. This is my financial disclosure. I'm consultant for Carl Zeiss India. So since the postgraduate students are the main listener for this particular program, so just wanted to tell about what exactly is the presbyopia, which is physiological progressive loss of accommodation affecting individuals in their middle age, regardless of any underlying refractive error, causing difficulty in sharply focusing for near vision. So there are different principles used to correct presbyopia. We used to do like monovision, that correcting one eye for distance and other eye for near, or even few of the excimer system, it do a multifocality treatment, or we used to even do increased depth of focus, what we do in camera inlays, or you can even try out for combined approaches. So these are the options available in the overall options with the lens procedures. You can opt for multifocal IOLs, trifocal IOLs. Nowadays, people are implanting extended range of vision IOLs. Coming to the corneal procedure, mainly presby LASIK, presbeyond, or even nowadays one more popular the treatment is supracore, or the previous one was intracore. And even people been trying with the something procedure called sclerociliary complex modification procedure. I'll not be talking about this procedure, especially laser rays, and also some of the people are trying with the scleral spacing device. So coming to one or two words about, even though my today mainstay of the treatment about the presby LASIK, but I just wanted to touch upon one or two words about the corneal inlays. The most popular one is camera inlays. Normally we have to implant in a non-dominant eye that increases the depth of focus almost, which is similar to the pinhole. How you make the LASIK flap, you have to insert underneath the LASIK flap. So I'm not talking about how exactly this is done. And there are other corneal inlays also available in the market, that is presbya. The principle is similar to that. The raindrop has been little bit popular in some of the countries where they do a reshaping inlay where it shapens the corneal curvature. But these are the few problems with corneal inlays. Definitely there is a reduction in the distance vision in the non-dominant eye, some amount of glare and halos with some amount of reduction in the contrast sensitivity. So let me come to the presby LASIK. It is a multifocal LASIK treatment, which is a biaspheric treatment. Here, what we do, we induce as a spherical aberration for depth of field. So, in that, there are two component peripheral presbyopia LASIK. What happens there? The peripheral, the central zone is corrected for far vision, peripheral myopic ring created for near vision. Sometimes you can reverse this treatment also. So this is the other the central presbyopia, because I don't have much idea about presbyopia. What we do in the central presbyopia, central steep zone for near vision, whenever the pupil is constricting and more physiological, and normally they'll have a stronger reading power. Especially these treatments are do very well with the hyperopic patients. Coming to the presbyopia, actually presbyopia normally used to do with the older version of the few of the examer system with the alligator system. Now some of the I think machine has come in something called presbymax. I think my friend Dr. Rohit has been doing in Narayan Netralaya with the swing machine. It's nothing but a biaspheric multifocal ablation. So what they do, the dominant eye is focused slightly more for distance and the non-dominant eye slightly more for the near. So even AMO also come with some of the concept. Previously, they used to try with the physics machine where they steepens the central zone for near vision and leaves the periphery for distance. So especially it is these treatments are people used to do more in the hyperopic patients. So these are the few problems with the presbyopia. Initially, compromise of especially for distance vision, patients used to get adjusted for till the 3 months. Adaptation is the problems, and some of the patient even complaining of night vision problems. So coming to the supracore, probably this is the latest of all, which is LASIK based procedure, which is performed on the Technolog's 217 excimer laser system. So what exactly they do in the supracore? It creates an elevation of 12 micron high, 3 micron in 3 in diameter in the central cornea along with the visual axis. So this is the sort of a varifocal principle that allows simultaneous good distance, intermediate and near vision. So this was the previously they used to do something treatment called intracore. So with the help of Technolog's machine. So it is performed in the stroma as a flapless procedure. But nowadays people stop doing this intracore treatment. What exactly they do here? They steepens the cornea by approximately 1 diopters. So changes in the biomechanics that produce the myopic shift approximately around 0.5 diopter. Here also the concept is same. Here it induces the negative spherical aberration. So the one more most popular treatment, I think probably one of our chief panelists also undergone this treatment. That is Presbyon, Dr. Sri Ganesh undergone this treatment. So this what exactly we do here? Uh, we before treatment, I just wanted to tell for postgraduate student, refraction is the key like any of the refractive treatment. So I do for every patient cycloplegic refraction, whether they are myopic or hypermetropic patient. Once your refraction done properly, then very important to know which is the dominant eye. Once you know the dominant eye, then you have to trial the micromonovision testing by making the non-dominant eye myopic by 1.5 diopters. So it's very simple. If when you're doing this micromonovision testing, suppose any patient complaint of cross blur, then these are the patient actually they don't do well after the treatment. You can repeat this micromonovision testing 2 times or 3 times. Still, if the patient say that I'm having double vision, I'm having blurred vision, then you should not pick them for Presbyon treatment. Then remaining is routine pre-LASIK evaluation. Normally, the software which is given by the ZEISS, that is CRS master, that will decide the treatment. You can do this treatment either their old version examer system, that is MEL 80 or MEL 90. So why we actually, what exactly we do here in this, we make dominant eye emmetropic and make the non-dominant eye myopic by 1.5 diopters. Along with that, we create a spherical aberration in both the corneas. As I said that we make the dominant eye emmetropic and make the non-dominant eye myopic by 1.5 diopters with the some amount of spherical aberration in both the cornea, then we'll have something called blend zone like this. The blend zone is the zone where the vision from both dominant and the non-dominant eye meets up and binocularity retains. So this is about the principles of press beyond. It, as I said that it is a principle of monovision with the increased depth of focus, spherical aberration control, neural separation, and blur adaptation. I just want to tell you a few words about why we pick this treatment, because if you do a rings in the cornea for both for distance and near, normally patient gets a lot of time to get adjusted. So the overall adaptation time takes very longer period. Coming to the that's what I was telling you, how we used to like suppress you. If you can imagine about the children with how you treating amblyopia, always the one eye will be like a blood from the other eye. This is how the concept behind this treatment. According to few of our senior surgeon, what they say that, see, I have been doing almost around 500 surgeries so far. 97% of the patient always wanted this treatment. Only thing is your pre-op evaluation is very, very important. So coming to the, what are the best points about press beyond? It's not depend upon the pupil size. You can do extremes of power. I have done up to 5 diopters hypermetropic. I have done myopic up to around 8 diopters depending upon the Pachy value, even up to the astigmatism around 3 diopters. All my patients had a very good intermediate and near vision, and around, as I said before, more than 97% of the patient adopt this treatment really well and without any significant night vision problems and contrast sensitivity changes. So coming to the which is the best option. So if you think about, okay, multifocal, I'm adding here multifocal IOLs also, because now most of us been implanting this trifocal lens. If you think about distance vision, intermediate vision, near vision, night vision problem, pupil dependent, and adaptation reversibility, if you think about all this procedure, multifocal IOLs, corneal inlays, Presby LASIK, supracore, definitely Press Beyond has got a very good distance, very good intermediate vision, very good near vision, no night vision dependent problem, and very important, it is independent of pupil also, faster adaptation, and of course, if any chance any patient come back to you with, if they are not getting adjusted, you can reverse this treatment. So in the probably the best and the safest presbyopic treatment available till date. Once again, I thank Chitra madam and the whole ARC team for this wonderful opportunity. Thank you, one and all.
Thanks, Dr. Krishna Prasad. You really gave us a very crisp and clear picture, and I'm sure the postgraduates would have learned the essential concept of presbyopic glassing. Dr. Sri Ganesh, are you there?
Yes, I am here.
Could you take the questions for presbyopic glassing, because you are very much into it?
Yes, I myself have undergone presbyopic LASIK and Presbyon, and I have done most of those presbyopic corrections from CK to Presby Max, multifocal treatments, Presbyon. So I have assessed most of them, and then finally I decided to undergo Presbyon. One of the questions I wanted to ask is, see, in multifocal, when you create a multifocal ablation on the cornea and ridges on the cornea, the epithelium has a natural tendency to, as a masking agent, and it smooths any irregularity in the cornea by relatively becoming thick or thin. So this ridges which you cause, the multifocality on the cornea, doesn't really last for a long time. If you do the topography and if you look at the epithelial maps, in a couple of months, basically the epithelium heals and then it smoothens over. So again, this effect would not last for a long time. So you have quite a bit of regression in these procedures. Plus, the other thing is, because of the multifocality, the night vision is quite poor. You get loss of best corrected vision. So this is something which is interesting to study. And in fact, ask Dr. Rohit also if he has done epithelial maps for his press patients, and what does he see?
What happens is, you're absolutely right. If the epithelium is irregular, prior to doing your surgery, the epithelium remodeling is going to be very aggressive. So this is one of the tests we consider before we do a presbyopic surgery, to look at the epithelial maps. If you have a donut shape, irregular epithelium, and there's a lot of difference in epithelium in the central 6 mm zone, then your post-operative will also become very irregular. The reason epithelium is very irregular is for two reasons. One is their ocular surface is bad. Epithelium being irregular is ocular surface bad. So it also gives you an indirect indication that if your ocular surface is bad, the healing post-op, like you mentioned yourself, is going to be terribly bad. So I'm sure that one of the two important things, apart from what Sir Kudlu sir mentioned, is the role of epithelium. The epithelium integrity before surgery is a direct predictor of what happens post-operatively. So if it is not very healthy, then I would give her at least 4 months time. I do the LipiFlow or iLight, one of these procedures. We put them on cyclosporin and trehalose. Trehalose is because trehalose is a direct relation to epithelial apoptosis. So after 3 to 4 months time, you see a very uniform epithelial remodeling. And then you do it, and then they do much better. That is something which...
No, but you can't actually see the multifocality on the topography because the epithelium kind of masks it.
Mask, absolutely. Post-operative is that.
And the most of the refraction takes place at the air epithelial interface between the epithelium and the stroma, where the ridges are. There's not much of difference in the refractive index, so you don't get that much of an effect. And even if the effect is there, then it is unpleasant for the patient because some of them are not able to tolerate this multifocality, and that's where most of these multifocal treatments actually failed, and most of them are kind of reversing to reducing the amount of multifocality and more towards a micro monovision kind of. Even I think Presbymax now, the latest software, they have reduced the multifocality and then they are going more towards the micro monovision and induction of spherical abrasion, similar to the Presbeyond software.
One thing I would like to add, what Dr. Kudlu said, is the most important thing in presbyopic evaluation is role of orthooptics and binocular single vision. If the patients have poor accommodation of convergence, they would really have a lot of problems. So evaluating that, treating that with exercises, home and office base, and then doing the procedure would be one of the points to be added.
And along with that, Rohit, I think we need to do eye trace also, just to make sure that patient doesn't have cataract. Sometimes whatever whatever the slit lamp examination, we miss that, then in the end you land up in a problem.
Absolutely.
Dr. Kudlu, what is I mean, for the audience, I think you can clarify, what is the difference between Presbeyond and laser blended vision? Because there is usually confusion and many of them use these terms interchangeably. So
I don't think the postgraduates will understand, because even for the experts it is, but I think you can clarify, Kudlu.
No, maybe we could take it up later. We go on to our next speakers, that particular issue, because I think this topic would get a little beyond what the postgraduates are going to understand. Thank you so much, Krishna Prasad. We really got a very good clarity about the essential things we need to understand as to why presbyopia classic has come into vogue, with the limitations which are there in the different processes. Thank you very much. Our next speaker is going to be Dr. Sahil Goyal, who is a cataract, cornea, and refractive surgeon from Ludhiana, who is going to elaborate on the most quintessential aspect of refractive surgery, that is topography, a detailed understanding.
Hello, good evening, everyone.
I think, Sahil, I think this is very important because they get topography maps to see in their Grand Viva, and also as a part of their doc with the instruments, etc. So this is very important.
Absolutely, ma'am. Will try my best to do justice to the topic given to me. Time 10 minutes seems a little less, but I'll try to cover the basics. I try to have some discussion with my own residents in the morning, that what are the problems they face while interpreting topography maps, and hopefully I'll be able to take everyone through. Thanks. Very good evening to all the panelists, and thanks to Dr. Chitra for giving me this opportunity. I would like to start with this evolution. This is one of my favorites, that how we have evolved from simple keratometry.
Sahil, you have to make the slides bigger. It's still on. It's not on the presentation mode.
Slideshow.
Okay,
Slideshow.
it is slideshow mode. Okay, sorry. Yeah, yeah. Hopefully
Yeah.
it is good enough. Yes. Okay, thank you. So we evolved from keratometry to video keratography to optical sectioning, and currently what we are using is corneal tomography, which is a three-dimensional modeling of the cornea, which involves anterior and posterior corneal surface. It probably essentially began in 2010 during my first year residency, when we first got access to Pentacam. And luckily, my thesis was on Pentacam, from where I got really in love with this topic of corneal tomography. So what we essentially do now is we make multiple optical sections of the cornea. With op scans, it used to be parallel sections with no overlap. With our current tomographers, they all have a central overlap. And essentially what we are using is Pentacam, Galilei, and Sirius. Uh, Pentacam, I think, is the most commonly used instrument, and I think that is what we are going to be talking about the most. And OpScan, because it involves optical sections without involving having any common overlap, is something which is a little obsolete. Whichever instrument it is, I think one of the most important things for the residents is not to really get distressed if they see a different tomography machine or a different sort of color coding. What essentially you have to understand is the interpretation of a tomography map or a basic quad map stays the same, irrespective of what instrument or what machine you are using. Before I go into detail, just in brief, a basic principle. Most of these machines use a Scheimpflug camera, which basically increases the depth of focus of the camera, whereby various objects at varying instruments at varying distance from the lens plane are brought into focus at the image plane. I'm not going to compare various instruments. I'll start with Pentacam, which essentially has a central camera to adjust for the eye movements, and a peripheral Scheimpflug camera which rotates 360 degrees, takes multiple cross-sectional images of the cornea, and using edge detection software, we can further go ahead and calculate the elevation of each point. Before I go on to interpretation of a topography or a quad map, for the residents, please understand that this thing, which is one of the oldest by Rabinowitz and McDonald, to date still stays the mainstay for diagnosis of keratoconus. No matter where you are, no matter which hi-fi machine you are using, please do not forget about the basics. And the basic was Rabinowitz-McDonald criteria, whereby a K value of 47.2 and inferior superior asymmetry of 1.4, these were the two cutoffs given. After that came KISA index, in which, in additional to this, astigmatism and skewing of radial axis was also considered. So I believe that if you are clear about these four basic criteria, you'll be able to interpret the corneal curvature maps anterior topography easily. So this is how a basic quad map looks like, and these are the numbers given. Uh, Depending on what color coding you are using, again, which is customizable, the color maps might look different, and machine to machine, the color coding might vary. But what you essentially need to look at is the basic numbers and the pattern. As I said in the previous slide, you need to look at the central keratometry and inferior superior asymmetry. You have to understand ectasia basically manifests in corneal curvature as a basic asymmetry. It can be inferior superior asymmetry, it can be right eye left eye asymmetry, or any asymmetry which can be initial manifestation of ectasia. Yes, posterior maps are also important, but let's first start with the front maps. So this is the axial map, and as you can see, 41.7, 42.3, the inferior superior asymmetry here is less than 1.4. And here, as you can see, 45.6, 53.2, there is high inferior superior asymmetry. This is one of the foremost criteria. Astigmatism with the rule most often will be normal. If it is with the rule, we mean that 90 degrees steep axis. If it is oblique or against the rule, that is sort of a red flag sign. After you have done read the corneal curvature, the Kmax, that is a maximum keratometry, the inferior superior asymmetry, and the astigmatism, next in a quad map, you can jump to the elevation maps, whereby it is essentially an imaginary sphere, or what we call a best fit sphere, and every point is calculated by how much microns it is above or below that imaginary best fit sphere. So the cutoffs used, say, generally in Pentacam, the cutoffs would vary from machine to machine. Generally, the cutoffs used in Pentacam for the anterior best fit sphere would be 15 microns, for the posterior would be 20 microns. Pentagam and Galilei probably differ in this way that Galilei generally advocates in its indices, saying that the toric aspheric is a better reference surface, that it increases the sensitivity to pick up keratoconus, while Pentacam essentially relies on best fit sphere, or as I will becoming an enhanced ectasia reference surface. So this is the basic sagittal map. These are the front and posterior elevation maps. This are the indices used by various tomographers to help you interpret the tomography. Please understand that these indices, like for Pentacam, we commonly use Bellin-Ambrosio display, are not the basic of corneal tomography interpretation. These are just external aids for the clinician to help understand and interpret the tomography easily or in a fast way. But this is not the basic. Please do not replace this with a quad map. If someone sends me Bellin Ambrosio and asking me that whether this is keratoconus or not, my first question would be, please send a quad map. And this quad map is something what continues to be the basic for interpreting corneal tomography. So if in 1 minute I can brief up the basics of Bellin Ambrosio, what they basically do in Pentacam is they exclude the central 3.5 mm zone, derive another best fit surface, and a difference between the elevation points of two is what is reflected in this difference. So depending on the cutoffs, they have divided yellow as form first and red as keratoconus. This is deviation of front surface. This is deviation of back surface. Pentagam gives maximum weightage not on the thinnest point but on pachymetry progression index, which is nothing but concentric circles drawn on the thinnest point of the cornea, and how the corneal thickness increases as you go from thinnest towards the outermost cornea. So this is pachymetry progression index, and the Bellin Ambrosio what we are using is the BAD3 that gives maximum weightage on ART3, that is ambrosial relational thickness, in which that is the thinnest pachymetry divided by pachymetry progression index. So every machine would give weightage to different things, and Pentagam gives maximum weightage in its index to enhance ectasia display or Bellin Ambrosio display, whereby this pachymetry progression index and the this bad display is given maximum weightage. But as I'll be showing, that bad is not the final decision maker. This is one of the external validation first studies about Pentacam, which showed the sensitivity and specificities of various Bellin Ambrosio deviation maps. The overall D is what we should generally look at if you are in a hurry. Individual DF, DB, all 5 deviation maps, sometimes you might get up alert that this is individual D is yellow or individual D is red. Please do not give any value to it. These from sensitivity and specificity data I have extrapolated, presuming a prevalence of 5 to 10%, that the positive predictive value of individual D as red will only be say 30 to 40%. Overall D, which we give maximum weightage to, even that would have around 60 to 70. That is best case scenario, a 2/3 positive predictive value. 1 in 3 overall D yellow or red might not be keratoconus, but at the same time they have a very high negative predictive value. So overall D of white, most likely 99.9% is not keratoconus. But overall D of yellow or sometimes even red, you again have to go back at the quad map or clinical, say look for seizuring reflex, look for retinoscopy, look for slit lamp signs to diagnose whether this is a patient with keratoconus or not. In absence of time, I'm not going to go much into details of Galilei, but quickly, I think Galilei has 2 or 3 advantages. It has dual Scheimpflug camera, it has auto alignment and motion compensation, and it gives more weightage to the central cornea in extrapolating a quad map, driving a refractive quad map. This is the basic of why in the central cornea a placido disc based imaging system is more reliable, and in the periphery a Scheimpflug camera is more reliable. I'm not going to talk much about Galilei, but these are some of the indices KPI and K probability, which, as I said, use slightly different methods to diagnose keratoconus. So every tomographer might have its own indices. Please do not get confused. Stay with the basic of interpreting a quad map, and the basic of interpreting a quad map stays in, first of all, sagittal curvature, whereby you look at inferior superior asymmetry, astigmatism, skewing of radial axis, especially if the astigmatism is against the rule or oblique. So I think this is one table which I think would be relevant for the residents especially. These are the suggested cutoff maps on elevation maps for Pentacam and Galilei. For Pentacam, on anterior best fit sphere 15 microns, posterior would be 20. For Galilei, if you are not using a toric aspheric, that is you are using a simple sphere as a reference surface, 12 and 16 microns will be the suggested cutoff for you to be able to diagnose keratoconus. All right. I think with that, I would like to end the talk. I think we are up with the time. If we have any questions from residents, we can take it up.
Naga, you keep looking at the moderator's link. And one very simple question. When do we ask the topo to be repeated in case it's has suspicious findings?
All right. Sorry, I didn't touch upon the quality markers. So in a basic quad map, say in Pentacam or every instrument would give you a QS, a quality marker. So again, Pentacam makes our job easy by making it color coded. So just like say for perimetry, Humphrey perimetry, you have positive and negative, that how reliable it is. Similarly for Pentacam, you have this quality marker and this should be okay or white. Yellow or red, ideally it should be repeated. Also sometimes you might have something what we call contact lens warpage, where there would be the two axes would not be bang opposite. There will be slight variation in the steepest or the flattest points, in which case you might want that there should be you ask the patient to apply lubricants and repeat the topography.
Yeah, like inferior superior asymmetry in a sagittal curvature map which doesn't correlate with the other findings, or a decentered apex. These are other things besides what Sahil has very well. Of course, some data points are missing is something very, very basic. You would immediately do it again, I guess.
So this is not visible in this map, but yes, sometimes Pentacam extrapolates the data beyond what it is able to capture, and those areas are highlighted in black dotted areas. So whenever you see, especially in the periphery, there are black dots, sometimes covered by the eyelid or some other obstruction, and you see black dotted structures, that means that data has been extrapolated to beyond what it has actually been able to capture. That would be another indication when you would want to repeat the topography. But essentially, Q value, quality value is essentially which sums up most of these quality markers. And if you want to be in a quick fix, then look at the quality value. If it is okay or white, then more often than not, you are good to go. If it shows yellow or red, then you probably need to repeat the topography. Severe dry eye patients, very irregular corneas, of course, it's very difficult to get a very good repeatable topography.
Sri
One,
Ganesh, talking about-
one question is how long should the patient stop wearing contact lenses before doing topography? I mean, that is something that the postgraduate should know for rigid lenses and for soft lenses.
Right. So for soft lenses, it would be at least 1 week. For rigid lenses, it will be at least 2 weeks. Lot of times, especially keratoconus, when you ask them to come for follow-up to establish whether there is progression in topography, patient sometimes you forget to ask. You'll get a topography and then realize that there has been sudden progression, and then you go back and ask the patient that when was the last time he or she used a contact lens, and he would say they used the RGP only yesterday. So sometimes that can lead to artificial steepening or flattening in various areas. So that's a very important question, especially for keratoconus patients, when you are trying to assess whether there has been progression in topography, that they should have discontinued the rigid lenses for at least 2 weeks. Soft are generally patients who are come for refractive screening. So before you take up any patient for LASIK and get a tomography, please make sure that they have discontinued contact lenses, soft lenses at least for a week.
Anaga, you have any questions?
Presentation. Excellent presentation, Sahil. I think you covered everything in 10 minutes. Just a couple of queries for the sake of postgraduates. I mean, how do you identify contact lens warpage? And secondly, about the color coding, why can't you directly compare two maps taken out of different instruments, and what is the kind of coding that we use?
Okay, so depending on how advanced, say sometimes most of the normal people will have corneal curvature values between say 40 and 48. So you do not really need to have small color coded changes for normal people, but in advanced keratoconus, where corneal curvature would go up to say 70, 65, 75, you will probably need to change the grading. The color coding scale used by various tomography machines are different. They are German and American scales, which at first appearance might look very different. So someone very used to seeing a op scan, when they see a pentacam or say a Galilei, the color coding will be different, but you have to interpret based on what the actual color coded map says from the side. So as you can see here, these are the numbers. So blue is 40, green is 42, 44 is yellow. So for normal patients, as you can see here, from 30 to 40, there is only a 2 diopter gap. And after 50, you suddenly have a 10 diopter gap. So 50, 60,
Sahil, I
70,
think
80.
we can't see your screen, Sahil, I think.
Yeah, you
Okay.
can just explain it.
Okay.
And also what they just need to know is what a keratoconus map looks like, what a keratoglobus map looks like, what a pellucid marginal degeneration looks like from their exam point of view. But just share your screen, I think.
Yeah, so I'm trying to do that. Yes, so I think screen is now being shared. So as you can see, most of the curvature maps would have this kind of gradation, 32, 34, 36, 38, 40, 42. So till 60, there is a 2 diopter difference. And after 60, suddenly it is a 10 diopter difference. For keratoconus patients, sometimes we would change this gradation. And this color coding, like for 40, it is blue. So from German and American scales, this color coding would vary. But the interpretation is not dependent on the colors. The interpretation is dependent on actual numbers. And what I think Dr. Ramamurthy first tried to ask was, how do you make out a contact lens warpage? So as I said, like this is a normal cornea where the two steep and the flat meridian are bang opposite each other. In contact lens, especially soft lens induced warpage, sometimes you would have more or less similar numbers, but the two axes will not be bang opposite. So it will be sort of a Y-shaped thing. Uh, Sometimes one might get confused with PMCD or sort of a crab claw appearance. But if you actually look at the numbers, numbers are not actually very different. So severe eye rubbing or soft lens usage can lead to axes which are not bang opposite to each other. And these patients probably need to discontinue lenses, give lubricants, and then maybe repeat the topography after a week.
Good, Kyle. That was a nice answer.
Could you also touch upon the difference, and when would you use a tangential map instead of an axial map, and the difference between that, just very briefly?
Okay, so sagittal and tangential maps depend on the reference surface, on the axis in the sagittal curvature. Tangential is basically the exacerbation of a tangential curvature. In that, you are not taking the corneal curvature and presuming that there is average from the central reference axis. Tangential curvature is the instantaneous curvature at that very point. Accentuated, it's sort of the small changes are really exacerbated in a tangential curvature. So sometimes that can lead to artificial noise, which probably is not really good. And sometimes that initially can lead to false interpretation of keratoconus. So as probably if my screen sharing, yeah, is still on. As you can see, this one is essentially high, with the rule astigmatism, 1.9 diopters, bang opposite, no swing. And if you look here at the tangential curvature, there seems to be a localized island around here, yellow color, which seems to be slightly elevated. This is 44, 42.5. This yellow island seems to be slightly elevated. So tangential curvature would tell you the exact location of the cone and how the cone is flattening. But at the same time, to detect keratoconus, sometimes tangential can lead to artificial noise because it is not averaging from the central reference axis. It is calculating the exact curvature at that very point.
Thank you so much. I think we'll move on now to our next speaker. Yeah, our next speaker is Dr. Pooja Khamar. She's a young leading light from Narayan Netralaya Group of 5 hospitals, and she'll be speaking on corneal biomechanics, especially with reference to refractive surgery. Yeah. Dr. Sahil, can you please stop sharing your screen so that she can start? Yeah. Thank you.
Thank you, ma'am. Thank you so much for the introduction. I would like to, just 1 minute. I would like to thank AIOS and the ARC team for giving me this opportunity to speak on corneal biomechanics and why is it useful in refractive surgery. At the outset, I have no financial interests in whatever I'm going to speak. I'm going to try to keep it as simple as possible because this is one question you all might be asked in either your paper 3 or 4, which is like your diagnostics or the future. So whenever you get a question on understanding corneal biomechanics, you need to cover these 6 topics, like what are the types which you can measure the biomechanics, the basics, you need to understand few of the indices which you need to write in your answer, the applications, the controversies, and you also need to mention what the future holds, what the future is about corneal biomechanics. So if you cover these 6 points, then I think you are very much on target with your answer. I'll be trying to keep it as simple as possible. So the various machines which are available to measure biomechanics are the ocular response analyzer, which is routinely known as the ORA, and the Corvis ST. And the Corvis ST, which is principle of the dynamic shine plug analyzer. So these are the 2 routinely used biomechanical tools. What do you need to understand in them? When the ocular response analyzer comes in a picture, you need to know two parameters, the two main parameters, which are the corneal hysteresis and the corneal resistance factor. The corneal hysteresis is nothing but the difference between the two applanation pressures, which is the P1 and P2, which actually represents your viscoelastic nature of the cornea, and the CRF, it is kind of dependent on your CCT, and it's more strongly associated with the corneal hysteresis. So these are the two, this is the diagram which you need to draw in your exam, how your ORA gives your map and the indices. The routinely asked and the maps which are shown in your exam in a lot of institutes and which is very much known as a biomechanical tool is the Corvus ST. Now Corvus ST in ocular ORA, you just need to understand that graph and the two parameters mainly, but in Corvus ST there are various parameters which you need to understand and keep in mind. So the first map would be the basic map would be the dynamic corneal response. Now the dynamic corneal response is a very important map because that is the first map which gives about you the information about how your applanation is, the quality of scan is, if the quality of scan is good or not. Because if you see here, it's a very like a normal line here, but if you see a multiple gradations here, that means your scan in any of these maps, that means your scan has not been taken properly. So the most important parameter here is the deformation amplitude. The deformation amplitude is nothing but the maximum displacement of the cornea from its initial point, and the value of it is given here. It also gives you the corneal thickness, the IOP and the corrected IOP. It gives you the non-corrected IOP and the IOP corrected based on your corneal thickness. So this is one of the most important map which you need to know. Now these are the two representative videos. One is the normal and one is the keratoconus. Actually the biomechanics has a very important role in differentiating your normal and the suspicious or the keratoconic eyes. If you see here, the normal is indenting this much, but in the keratoconic eye is highly wobbly and it indents more than what your normal looks like. The total millisecond, what it measures is 30 milliseconds. So it measures for around 30 milliseconds, and your keratoconic eyes will be more wobbly and it will indent more. The deformation will be even more than that of normals. Now, what you need to know is these are the stages of the dynamic corneal response. Whenever you give a puff of air, actually the biomechanics is measured with the puff of air. Whenever you give the puff of air, there are various time like levels of the deformation. And these are the ones which you need to know for your answer and which you need to write. The most important being the deflection amplitude, the stiffness parameter SPA1, and the deformation amplitude, which is the definition given here. This third comes is understanding indices. Now, why are the understanding indices important? As we are moving, advancing in refractive surgery, the indices are also becoming more and more in depth, they are becoming more vast, and we need to understand them in depth. So the second map which you need to understand is the Vinci-Giura screening report. Now the Vinci-Giura screening report, it gives you an SSI parameter and it gives you this all various parameters, but the most important parameter is the Corvus biomechanical index. Now what is Corvus biomechanical index? Corvus biomechanical index is nothing but it is a composition. It's a total indice which merges the deformation amplitude ratio, the integrated radius, the Ambrosius relational thickness. It takes your relational thickness into consideration. So that is why this is a better parameter compared to your deflection or the deformation amplitude, because it takes your thickness also into consideration and the stiffness parameter. And at the combining all these parameters into consideration, it gives you one value of CBI. Now the normal value of CBI is anything less than 0.3 is normal, 0.3 to 0.5 would be suspicious, and anything above 0.5 would be abnormal. The next parameter which came into picture was a combination of BAD-D, which my colleague Dr. Sahil has already explained very nicely. BAD-D was combined with the CBI, which is the Corvus biomechanical index. So the tomography and the topography was combined to give you a total biomechanical index. So here also the value of TBI is very important to differentiate between the normal and the suspect corneas. Your topography will tell you very clearly whether it's a normal or a keratoconic cornea, but the biomechanics comes into picture when you have to differentiate the normal and the suspect KCIs, which is the FF cases, which when your topographies are not giving you a clear picture. So as I said, the TBI value, anything above 0.29 would be suspicious, and CBI above 0.5 would be abnormal. And this was a report, like a study done by Professor Ambrosio and group, where they said the sensitivity and specificity of both of these indices, when you take this as a cutoff to suspect ectasia, was around 90 to 93%. The next comes, whenever you talk about biomechanics, it's based on the modulus. It's based on the tangent or the second modulus, and there are various stresses involved, stress and strain mechanism involved in considering your biomechanics. So this is all what you need to know, and you just need to name them when you are talking about modulus and the corneal biomechanics. Now, why is it important? Like we all know that the biomechanics is dependent on all of them. So we have one more parameter, which is the stress strain index. The stress strain index is based on the Young's modulus, and it is derived from one of few of this finite element simulations, and it is given as a curve, like a J-shaped curve. Now, these curves are representative of the intrinsic elastic properties of the cornea. If the curves are shifted towards right, which is here, which is less than 1, it means your cornea is softer. However, if the curves are shifted towards your left, which is the value is more than 1, it means it's a stiffer cornea. But however, the limitation here also is that this is the normative value based on adult population of 50 years or more. So whenever you're understanding that for a younger patient, you have to keep this parameter into, you cannot take this value as like, okay, it's less than 1, it's abnormal. No, you have to keep other parameters and your scans also into consideration. But where is it more important and how it comes into play? As your topography gives comparative map to know whether it's your keratoconic eyes or whether your condition of the disease is stable or not. Now the biomechanics also gives us an aid. You can put the 2 visits of the biomechanics into your machine, like into the software, and it gives you whether the stiffness of the cornea has changed or not. It will show as it has not changed at all, not significant change. Your pre and the post treatment visits are the same. Or it will say that, a post treatment, for example, your refractive surgeries eye, post treatment, it has become softer. Or it will also tell you whether the post treatment your cornea has become stiffer or not. So here is the main place where your SSI parameter comes into consideration. Just like your topography comparative maps, you can use the SSI comparative maps to see the treatment outcomes of your cross-linking, your refractive surgery, post-refractive surgery. If you are suspecting ectasia but you're not sure, you can compare your 2 visits of SSI and know whether the cornea has become softer, whether it's not changed, or whether it's become stiffer post cross-linking. So this actually helps in gauging your treatment outcomes like your topographies. The next thing is controversies. Now, these were the applications where all you can use it and the indices. But there will always be controversies. For example, if you see this case is not a very normal case. This patient came in for refractive surgery opinion, was a low myop, -2 dioptric spherical. If you see here, there is some amount of asymmetry present. However, a bad D was normal. And even though there is a suspicious topography and some amount of inferior steepening present, your biomechanics and all the parameters are within normal limits. And these are how the epithelial map looks like, which are very important in your refractive surgery. And Dr. Srikanesh and Dr. Rohit had a wonderful discussion on it. So epithelial maps are also within the repeatability range, and the keratoconus summary showed that this was a normal cornea. Though it's looking suspicious, it said that all the parameters were within normal limits. Now, this is the second case, classic case of a keratoconus. Bad D, yes, it's suggesting of keratoconus. However, if you see here, the CBI is 0.03, which is very well within normal limits. All the other scans are telling that it's a keratoconic eye, but your biomechanics is suggestive of that it's a strong cornea. Now, what do we do with this patient? So now this is about the future. In future, we now are working on polarization sensitive OCT, where you can image your collagen and see how the orientation, the density of your collagens are in your eye, and how in each right eye and left eye, and how it correlates with your indices. So if you see the first patient where the topography was suspicious, but all your parameters were normal, this is how a normal orientation of the collagen looks like, the retardation maps. And if you see the patient, it is also healthy, dense collagen. The orientation and of the fibers are very well within normal limits. This is the first patient. So suggesting that, yes, the biomechanics, which is showing it has to be a stronger cornea, it is because your collagen is healthy here and dense enough. That is why your biomechanics, this is a strong cornea and not a weak cornea. Now, interestingly, here, if you see that this patient is a FFK, a suspect keratoconus, a keratoconic eye. This is how your normal looks like. Why was the patient having a normal CBI? Again, if you do the collagen mapping here, the collagen imaging, if you see the collagen are very nicely arranged. The density and the orientation of collagen is not as bad as that of a keratoconic eye. It is very much near to the normal eye. So now, why is this important? It is important because if in this strong cornea, if in this type of a collagen, if you, one thing would be that patient you can keep under observation, there is probably no risk of progression. And second thing is, okay, if you have to do a cross-linking also, if you go ahead and do a cross-linking, because of a good orientation and the density of collagen, post cross-linking, your patient might land up in scarring. So you have to be very watchful when your biomechanics is trying to say something. This is, I've just shown these two examples along with the collagen imaging, that biomechanics is not always telling you the fake thing. It's sometimes trying to tell you the truth, and you need to sometimes rely on your biomechanics. And probably you can keep this patient on like a watch and observation and not do any procedure for this patient. What is the future? The future is about artificial intelligence, where you can simulate your treatments, be it LASIK, SMILE, or PRK. So this was one of the papers which was there published as a work of my PhD, where we simulated that when we can predict the outcomes of the refractive surgery, be it LASIK, SMILE, and PRK, and compared it with how the outcomes would be if we can predict it preoperatively without doing the surgery. So what we have done now is we have converted this into an artificial intelligence based software. You can see the screen here. After this, I'll be showing you a video. This is the first ever software where you can predict the outcomes of refractive surgery, whether you do a surgery, whether your patient post-operatively would be fine, or whether the patient might land up into ectasia, or it is safe to avoid a surgery. So this is just a quick video of how this software works. This is the software AccuSim. You just have to, you don't need any elaborate thing. You need to enter your Pentacam data, your Corvis data. Once you have all this data, you need to enter, you just need to import your CSVs, which is there already on your computer. And you enter your flap thickness, your refraction, your cap diameter, optical size, the thickness of the epithelium. And it takes, at this point of time, it is taking around 45 minutes to run, but we are trying to work on it. And in future, it will be just like your any other topography or biomechanics report, which will be right away in the hand. And then you, at the end of it, you get this report of what the outcome of the surgery is going to be. So if you can see here, it gives you that this is the preoperative corneal stiffness, which is given by the K mu, and this is the predicted post-operative corneal stiffness. It also tells you whether it is in the normative range or whether it is not, whether it's in the abnormal range, whether preoperatively it is healthy to operate or not. So it gives you a lot of information and tells you whether you can go ahead with the surgery or not. And it's a very elaborate software. It has taken like thousands of eyes into consideration from various surgeons across the world. And this work has been done in collaboration with Oculus. So, and just to say that how well it matches, the dotted line are the simulation, and the straight line, the continuous line are the ones which were which were actual patient outcomes. And if you can see, they are very well matching to the simulation and the patient outcomes. So just to summarize, your biomechanics can help in detecting the mild forms of early stages of ectatic corneal diseases, where your topography is not trying to give you any information. It also helps in early detection of post-refractive surgery ectasia. It helps in tracking progression of keratoconus, and it helps to tell you whether, is it like, it helps in timely intervention of whether to do a cross-linking and not. And what is the real future? The real future is the AI-based prediction, which you need to know, and you have to also mention about the future when you write your answer. Thank you.
Thank you, Pooja. That was a very crisp, wonderful talk. After having heard all that Pooja has to say, I have just one question, because I think we'll be running short of time. One question to the expert panel, and of course, Pooja too. Assuming that if every other way the topography looks normal and the TBI alone is in variance, even the other CBI and bad is okay, would you veer away from what refractive surgery you had chosen Would you think of waiting, or would you think of doing a PRK extra, or would you still do SMILE or femtoelastic? Is the question I have to all of you.
So at this point of time, I would put a lot of efforts on CBI. Reason is CBI is independent of a lot of topographical issues, and CBI, TBI, which is it involves a lot of topography, and topography can be heavily affected by tear film to epithelium. So if CBI is abnormal and TBI is normal, then I would give a option of PRK and not extra, because PRK itself has a strength of an extra. I think that whole extra discussion is going to be done by Sharon at the end of we have a talk by then. But more and more insight is coming up, and I'm sure the machine was not wrong all this way. This may not be relevant for the PGs who are listening to us now, but of course they will also be part of this once they get into a fellowship. Or what I would like to say is, as our understanding is evolving, what are previously misunderstood concepts are becoming much clearer. I think when you start looking at it holistically.
Anything else to add, or shall we go on to the next talk?
I think, what Pooja spoke about, I think may have gone over the heads of most of the postgraduates. And I think they should know basically, basically.
A great job, but I think for a short note, for all those kind of things.
Yeah. So you should know the applications. I mean, the applications of biomechanics in various fields. And I think a few other points like corneal biomechanics, adjusted IOP is something which is important that the postgraduate should know, because post-refractive surgery, when you measure IOP and you want to look at glaucoma detection, glaucoma progression, this is very important. And also after cross-linking, if you want to see if the cornea has improved. But biomechanics itself is an imperfect science as of today, and cannot be completely relied upon. Of course, the future, I think the other thing is the Brion microscopy, which they can mention when they are writing about the future of corneal biomechanics. But of course, the other applications are also there. But overall, I think it was a detailed talk for 10 minutes, but I don't know how much the postgraduates would actually be able to kind of recollect and then write about it.
In fact, it came for glaucoma first. Yeah. On the biomechanics concept was more for glaucoma. So I think they need to write 3 things, which Sri Ganesh has very rightly said, that 1 would be for refractive surgery, 2 would be for glaucoma, and 3rd would be for collagen cross-linking. But
as far as Chitra's question goes, I think you should not just look at one parameter, either the CBI, CBI or TBI. It's not just one parameter. You'll have to look at the overall picture. You'll have to look at age of the patient. You'll have to look at their contacts. We'll have to look at other hormonal changes. If the patient has gone through a pregnancy, or if they have a history of eye rubbing, and a lot of other epithelial maps. I think you should take in all these and then take a decision about whether you want to do refractive surgery. I mean, that's my thought. You can't just look at a single parameter and decide whether this patient is fit or not.
I think.
Shall we move on, Maya?
Yes.
Thank you, Dr. Pooja. That was a really great, insightful talk. I'm sure the PGs would have appreciated it. Our next speaker, Dr. Mohita Sharma, wouldn't be joining us. So I would request Dr. Chitra ma'am, our dynamic ARC chairman ma'am, to speak to us on surface ablations.
Yeah, you can see this? Yeah. Is my screen visible?
Yes, it is visible.
Yeah. So Dr. Mohita let me know just some time back that she's got caught into an important meeting. So I'm filling in. I hope I'm able to do justice to this talk, which was spoken for a different forum earlier. So surface ablation is an important talk for the postgraduates. So let's try to make it as relevant to them. Essentially, what we need to remember is the excimer laser and PRK is what actually opened the realms of refractive surgery 2 to 3 decades back. But what happened at that time, why they got temporarily stumped was the protocols were not well defined, and the high refractive errors were being corrected on a PRK mode, and we did not have the wound modulating agents. So haze and regression were the bugbears at that time. There was a study which looked at the way the LASIK survey in US and Europe, and what they came to find was around 2007, there was a resurgence of surface ablations. And what was also interesting was that they came to realize that there was a small group of eyes which were coming up, which had developed iatrogenic ectasia in low to moderate myopias. So then the proponents got together and realized that we had to temper our understanding and usage of refractive surgery, and certain ground rules were laid. As far as surface ablations were concerned, the advantage here is you are able to preserve more tissue. You are not making that vertical cut on the flap. So this becomes an advantage in thinner corneas. Also in moderate dry eyes, wherein flap-based procedure, there is greater cutting of the corneal nerve plexus. And also because biomechanically, we are not making that vertical cut on the flap. The anterior collagen lamellae, which are very tightly packed in the superficial area, they are not getting as strongly bisected when you're doing a surface ablation. The other reason why surface ablation came back was also the smooth laser profiles with the flying spot lasers with the aspheric patterns which came in. So these seem to do a better addressal of the higher order abrasions, and our understanding of the epithelial maps which are there now took us forward. However, with surface ablation, it makes sense to limit our corrections to not more than 50 to 75 microns largely, although there are certain centers wherein they are doing high myopic errors too. But as an average, I would say up to -4 to -6 should be our cutoff. We should avoid making optic zones smaller to correct more, because this again causes haze, and also haze is seen even in the hyperopic ablations. Now, mitomycin C is come of use in surface ablations, but it continues to be an off-label use. There have been some interesting reports which have said that there are less occurrence of ectasia in mitomycin-treated surfaces, but you cannot conclude on that. But what we need to know is mitomycin does not deplete the functional reserve of keratocytes. It actually prevents hyperproliferation of keratocytes and especially those irregular generated material which cause scars. So then, keeping surface ablation and the mitomycin together, we are now able to correct standard refractive errors, thinner corneas. We could do post-flap complications wherein the primary procedure failed. It can be used as an enhancement tool. It can be used as PTK options, and more also now in mild to moderate keratoconus, we are able to use it as a topographic regularizing treatment along with cross-linking. So I'm just briefly showing you, like if you've had a vertical breakthrough in a femtosecond laser, you can't do that procedure now. So you could do a surface ablation in a small eye wherein you've had an inadequate flap, or you've had a buttonhole, or you've had a partial flap. These are all primarily because they were topographically, these were not ideal cases for doing microkeratome procedures. So in all of these, if you do a surface ablation, you are able to salvage the size. And again, in post cataract, especially in the premium IOLs, if you have a residual refractive error, you could do surface ablation as a bioptics procedure. And these are different ways forward. The other advantage is now we have more ablation profiles to work with. Like earlier, there was the wavefront guided, which was essentially looking at the refractive error and correcting the higher order abrasions. Then came in the wavefront optimized, which continue to be very promising. And now today, we are able to do topo guided treatments on the surface ablation platform. We also have come to understand that epithelium should be removed from the periphery to the center, either by mechanical debridement or alcohol. But it's important that you avoid prolonged exposure on alcohol, avoid overhydrating these corneas. Remember, we should avoid treating thinner corneas. Just because I said it needs lesser tissue to be removed, you cannot get overly aggressive with these thinner corneas. We should leave at least enough 300 as a residual bed. And of course, epithelial map teaches us a lot. As far as the different modalities of doing it, there was a time when LASIK was popular, wherein in all of them, first you use chilled BSS to cool take care of the pain component and the inflammation. And then a Trifine is used wherein 70% absolute alcohol was placed for 20 seconds. And this loosened the epithelium and allowed the ease of removal. Besides the mechanical debridement, you could do the EpiLASIK, wherein this plastic separator was used to separate the Bowman's and the basement membrane and create a cleavage plane. Or you could do a transepithelial PRK, wherein a PTK mode is used to remove the epithelium, and then you go on to doing your refractive correction. Earlier machines, we had to alter a nomogram. We needed to add a 0.5 to our refractive correction when you're doing a surface ablation treatment. But now we have the Streamlight, which has come, which has its own inbuilt algorithm, wherein it gives those extra pulses in the periphery, which counter the hyperopic shift which can occur when you're removing the epithelium in a PTK mode. As far as the pain is concerned, we could use chill BSS to chill the nerve endings. You could place ice packs about 15 minutes before, or you could place a BCL following the procedure to allow the epithelium to cover up properly, or Acuvale, which is a contact lens with a non-steroidal antibiotic drop soaked, which could be used as various modalities to address the pain component. The haze is a big challenge when you're talking of surface ablation. And when does it come? It comes when you're treating high refractive errors. If there has been some reason for delay in epithelialization, the stromal surface is irregular, when there has been an excessive exposure to UV light, that's why you need to insist on wearing protective dark glasses for these patients. If you have inadvertently damaged the basement membrane or injured the Bowman's membrane, or if your mitomycin sponge does not adequately cover the area of cornea to be treated. And this haze could start as early as very early weeks and go on to 6 months. Today, we better understand how to deal with this haze which comes with surface ablation. One, we have the advanced ablation profiles. We have the flying spot lasers. We now use large optic zones. The sudden transition zones are again issues which can cause haze. And the alcohol assisted does better than the mechanical debridement. We use protective eyewears. We use systemic usage of ascorbic acid, like in our centers, we use it BD dosage for 6 weeks. Then topical steroid drops, which has to be used on a tapered regime over 2-3 months. And of course, cyclosporin and plasma-rich growth factors have to be added on. Now, mitomycin, which I had earlier alluded to, has anti-proliferative and cytotoxic effect. And the usage of this now has expanded its options to not only use it for every routine case, but those areas where you expect regressions or retreatments or post-RK or keratoplasty operated eyes. The challenge in surface ablation is, because we're going to be using steroids for a longer period of time, and because these are young myopes, they could be steroid responders. Supposing you are left with you notice a haze, these patients might have stopped their topical steroid drops. You could start them and deal with that. Or sometimes you may be forced to do a PTK and remove the area of haze and apply mitomycin C and deal with that moment. Now, the understanding of epithelial modeling tells us that the epithelium healing is more based on the rate of change of curvature. And this remodeling is something very specific in myopes and in hyperopes. So the present usage of larger optic zones is what comes to play in helping us to have lesser regressions and better refractive predictability. However, there is a high variability in KC eyes, which is where we are able to understand a little more in diagnosing early cases. Epithelial mapping, besides great use in surface ablation, has also these uses of diagnosing an early KC, looking at our CXL outcomes, and also evaluating the refractive surgical complications. Now, this is a fairly routine topography which you're seeing, but if you have an access to the epithelial map, you understand that if you could feed in an average of 60 micron instead of the standard 50 micron, you are able to do better. Now, surface ablation has come to play even in enhancement procedures, because what we now understand is within 3 years, you could relift the flap and go ahead and treat with less chances of epithelial ingrowth occurring. But beyond 3 years, there's a greater possibility of epithelial ingrowth. And beyond 3 years, it now makes sense to do surface ablation as a tool for enhancement procedures. We have now to understand topo-guided treatments better. Now, in topo-guided treatment as a way of tool of treating the surface with the surface ablation program, like this was a patient who had a free flap and it was not appropriately placed and he ended up having a very irregular cornea. So herein, you are able to do a bimodal treatment, a combining a myopic and a hyperopic combination program. You're able to regularize the topography, and after 6 weeks or 3 months, you could go ahead and do a refractive correction on a wavefront optimized mode and get to the moment. Now, we've heard a beautiful talk of biomechanics and Ora and Corvus. So then with that understanding and understanding little more of cross-linking, we now feel that yes, this has a role in restoring the strength of the cornea in some extent. Of course, the query was that would this have a refractive impact? So, but what we understood now is that if you have a borderline topography, a low diopter of correction or retreatments, you could do surface ablations with cross-linking and using half the fluence and the duration of time as specified. The only important thing you need to understand here is you would have to use mitomycin even if you're doing a PRK extra, because mitomycin is not going to reduce the effect of cross-linking, but it would take care of the migratory keratocytes and will prevent the haze occurrence. Surface ablations has come to play its role in form frustrate keratoconus. Like what we now know is that if you are able to make a small steep cone, make it a broader cone by flattening the central steep area and lifting up the mid periphery and making it a larger, flatter cone, it would better address the biomechanical strain of the cornea. So there were a number of proponents who came forward to say that yes, go ahead, let's do topo-guided PRK with cross-linking. But then the other query was, the controversy was, would you do topo-guided PRK and cross-linking at the same time? Yes, it made sense because you are doing a topo-guided PRK. If you were to cross-link the eye first and then later do a topo-guided PRK, you would have actually removed the cross-link tissue. And again, we do not have nomograms for a cross-link tissue, so we would not be able to do an appropriate refractive correction on these eyes. So then a lot more understanding came in and we started understanding that yes, if we are going to do a topo-guided PRK on early and mild keratoconus, you will do it simultaneously. And then the other thing we understood was that if you could do a PTK mode of removing the epithelium, this seemed to by itself regularize the topography to an extent and improve the BCV of these eyes, and then go ahead and cross-linking seemed to be the way to go. Taking you through one more example in what I had discussed earlier. Now, this was a patient with a Fram keratoconus and an uncorrected vision of 636. So if you are able to do a topo-guided treatment in these eyes, like if you could make the manifest 0 and you look at the map, you are guzzling up 27 micron of tissue in these eyes. So understanding that you could go up to 50 or 60 micron, if you're able to bring out the full cylinder correction or most of it, along with some amount of the spherical correction, and you look at the anterior float and look at the pattern of ablation which is there, and if these correlate, then you could go ahead and do a topo-guided treatment on a PRK mode, and then go ahead and give a full bone cross-linking of 10 milliwatts for 10 minutes, 9 milliwatts for 10 minutes. Now, this is the third case which I wanted to show you all. This is a post-LASIK ectasia. Even in post-LASIK ectasia, if the corneal thickness allows, you are able to do a topo-guided PRK with cross-linking and go ahead and deal with them and give them a vision, uncorrected vision of 6/9 from the poor BC wave which they had earlier. So essentially, I would like to conclude there's a lot more which has evolved in topo-guided PRK. But what I would want us to all understand is the way surface ablation stands today, it's become a major portfolio to treating thinner corneas, to treating complicated corneas, to treating post-LASIK complications. And this has to come to hold a major place in the refractive armamentarium. Yes, there is a longer recovery time. We have to be realistic in our expectations, but yes, it has come to stand again. Thank you very much.
Lovely talk, ma'am.
Yeah, but
really nice.
In a last minute hassle. Yeah. So shall we go into questions?
Yeah, just for the benefit of the PGs, ma'am, would we want to just say how much of mitomycin and how long would you keep for when you do?
I think that again varies with the individual practices. Largely, I think many of us are using it 0.02% of mitomycin. Keep it for 30 minutes. We use it for all our cases, 30 seconds, irrespective of a lower diopter correction or more. But there are experts who keep mitomycin for every diopter 10 seconds of exposure, and they seem to be confident of treating up to -7 and -8 diopters. Dr. Rohit, do you have some information on that?
Yeah, we use every diopter 10 seconds. and I try to keep it more for a -3 and above. If it's a contact lens user, then I would keep him for even for a -1. Or if it's a dry eye patient, if it's a poor ocular surface with meibomian gland dropouts of point more than 20 or 25%, then I would keep for even if I'm treating a 0.75. The reason is not all patients' scar is related directly to the ablation depth. Anything is related to the state of your ocular surface, and for that, so that means your mitomycin is dependent on people. There are two schools of thought. One is you blindly treat everybody with mitomycin, whatever power you do. The second school of thought is that you treat it based on these parameters. How good is your ocular surface, your epithelium, the meibomian glands? So that's the reason a lot of people do a -7 and 8. They don't use mitomycin also, and still they get away without having scar, because if your ocular surface is healthy, the scar somehow, even if you treat -7, it gets covered up. But for the practical reason, every 10 microns, every 10 seconds for a diopter treated. That means if you're treating a -3, then you'd keep it 30 seconds. If you're treating a -4, or 40 seconds.
How long would all of us like to keep the BCL on in the eye? Is it again something which varies with everyone, or you keep it standard 4 to 5 days?
We do a lot of trans PRK. Trans PRK usually is 2 days, 2.5 days. It's completely. There are times when some people, like I said, some people do have a longer healing phase. So then probably we keep them a little longer.
Dr. Ramurthy, you have anything to ask?
Not much. I mean, I think everything has been covered. Suffice it to say that we all started our laser vision correction with PRK, and it was not just the better understanding the science of laser vision correction and the availability of mitomycin C. It's also the fact that we shifted from broad beam lasers to flying spot lasers, which made much less energy onto the cornea, because of which there's a resurgence of interest in surface ablation. And suffice it to say, if there is a doubt about the corneal hysteresis, and if at all you want to do a laser vision correction, surface ablation may be the way to go beyond SMILE or LASIK procedure, because as far as preservation of hysteresis is concerned, as of now, we believe that PRK is the best way to go.
Speaker?
Yeah, shall we move on, ma'am, to the next speaker? Yeah. Yeah, so our next speaker is the dynamic young man, Dr. Rishad Shroff, who is the consultant cornea, cataract and refractive surgery from Shroff Eye Hospital and belongs to the clan of ambitious young leaders. He's going to speak on microkeratome LASIK, the basic essentials. Can you start screen sharing, sir?
Yes, ma'am.
Yeah.
Are my slides visible, ma'am?
Yes, yes.
First of all, I would like to say thank you to Dr. Chitra for allowing me to give this talk and giving me the opportunity for the same. So I'm going to be talking about microkeratome LASIK and its essentials. I've divided my talk into basically selection criteria, the principle of the microkeratome. I'll be going through the various parts of the microkeratome, the procedure itself, and common complications that we encounter while doing MK LASIK. Now, an ideal candidate for LASIK, it's important to understand the patient's motivation. They should want to be independent from glasses. They should want to be independent of contact lens usage as well. There are cases where we've discussed already about warpage and the vascularity, which we have to take into account, because during MK LASIK, there can be bleeding from the periphery if there's a lot of vascularization post-contact lens wear. The patient profession, again, is important to understand, because in contact-based, if they're in contact-based sports, for example, you would want to avoid a flap-based procedure. The professional reasons, like say if they want to apply for a certain job, then they're keen on doing LASIK, and of course for cosmetic reasons. While understanding which cases, it is important to also understand which cases we should not do LASIK in. So medical history is important, because in certain connective tissue disorders, there's poor healing. Again, patients who are using isotretinoin or medications like amiodarone, there's poor wound healing in isotretinoin, their dry eyes. So these cases you would want to avoid laser vision correction. The ocular examination is fairly standard, but you have to make sure that there's a stable refraction that should be there before we are going ahead with a LASIK or a laser vision correction procedure. The external evaluation is important. It's important to evaluate the pupils. Large pupils may cause postoperative glare and halos. And an orthoptic evaluation is also important because these patients, if they have a phoria which gets unmasked later, they may give you trouble post the surgery. Slit lamp examination routinely look for things like gross signs of keratoconus, and there are a couple of other things which I'll come to in the subsequent slides. Corneal topography, I think Sahil already covered. I'll mention just what is important from the microkeratome LASIK point of view. IOP measurements, cycloplegic refraction, and a dilated fundus examination is necessary to rule out fundus pathology. Now, in slit lamp, one thing to be aware of is when you have a small corneal scar in the periphery, a microkeratome LASIK does better. This is one of the instances where a microkeratome LASIK is better than a femto LASIK because that scar is a potential weak area through which a vertical gas breakthrough, which is like a buttonholing in a femto LASIK, can occur. So in these kind of cases, it's always better to do a microkeratome LASIK. On slit lamp examination, it's also important to look for gut data because certain corneas, you may have a good thickness, a very good thickness, but they are predisposed to having Fuchs dystrophy, and therefore you should look for this before doing a laser vision correction. For microkeratome LASIK specifically, avoid it if you have a very flat cornea. So normally what I take is between 42 to 46 diopters. Anything flatter than that, I avoid a microkeratome LASIK. Anything steeper than 46, again, avoid a microkeratome LASIK. So what is a microkeratome? It's a precision instrument with an oscillating blade used to cut a corneal flap in keratomyelitis. It was actually discovered, the principle was discovered by Barreker, and it was used in the ALK procedure initially, which was not found to be a very successful procedure, but that's where the microkeratome came into being from. Now, the principle is that the normal cornea is not flat. Now, what we want to achieve is an applanation where we flatten the central cornea so that the oscillating blade can create a hinge flap that is reflected back to expose the stroma for the excimer laser application. So a microkeratome is capable of creating a thin lamellar slice of the cornea at an appropriate depth, which varies from about 90 to 140 microns. The interface should be smooth for the excimer application, and there should be appropriate diameter and hinge of the flap. So this is what the flap anatomy essentially looks like. When you see it's the flap, I've shown it as a reflected structure. The hinge is what connects the two together. Now, a hinge length of about 5 millimeters or more than that is good because a narrow hinge causes problems like striae and flap slippage, which leads to suboptimal postoperative outcomes. The stromal bed, at least 8 millimeters, preferably slightly more than that, should be available for ablation. So most of the times in our microkeratome LASIK flaps, they're about 9 millimeters or slightly more than that. Coming to the components of the microkeratome, there are suction rings and vacuum pump. There is checking whether adequate vacuum is achieved by the help of an intraoperative tonometer or an applanation plate. The oscillating blade is one more component, which is the fast moving blade that creates the flap, and the method of moving the blade in the forward direction, which can be either manual or with the help of motors. So I'm just going to show a few videos regarding the components. This is from the SBK, the Moria microkeratome, the 1U plus SBK. These are actually the rings. They come in various different sizes of 0, +1, +2, and +3. The larger the white to white diameter, so it's important to look at the white to white or the corneal measurement, choose a lower value of the ring. So the lower value of the ring has a larger aperture. This sits on top of the cornea and applanates it for the blade to actually move across. There is a tubing that connects the console to this particular ring. And what you can see that being rotated, that is the stop. So a stop is necessary in a microkeratome LASIK. Otherwise, you would have what is essentially like a free cap. The stop prevents the microkeratome from advancing too far and therefore creates the hinge. And you can see that arrow points to where the stop actually is. The suction ring and the vacuum pump ensure adequate applanation. If there's inadequate applanation, then there can be a problem of a thin flap or a partial flap. At the base of the suction ring, like I told you, are these golden or blue colored stops. These prevent free caps. This is actually a video showing the console of the Moria system. What you can see is the vacuum being shown here. When we press the foot pedal on the right, which is a vacuum foot pedal, that gets generated. How to test it is what I was showing in the video initially, where we kink the tubing to actually check whether the console is generating the vacuum properly. The other foot pedal moves the microkeratome in a forward and backward direction. On the patient, how to practically see whether suction has built up is one, there will be a pupillary dilation. There will be a blackout. So the patient will say that they cannot see anything at that particular time once adequate vacuum has been achieved. Intraocular tonometer is very important in all cases of microkeratome LASIK to ensure it confirms that the IOP is obtained, a high enough IOP to applanate the cornea or flatten it. This must be performed in all eyes when you're doing a microkeratome LASIK. So this is a video showing how we attach the blade to the handpiece. You have to make sure that it's tightly and snugly in place so that it doesn't move around and vibrate. It has to move smoothly forward because it's a high speed oscillating device. 90 microns and 130 microns are the standard blades that you get with the SPK. The 90 microns is for better biomechanical stability. However, the thinner flap causes a higher risk of a buttonholing, and risk of striae can be higher also in these cases. 130 micron flap causes less flap slippage and less striae. However, the biomechanical stability may be a little less in these cases. This is just to show how we go ahead with a dry run of this. Always do a dry run before you actually go ahead and apply this to the patient's eye. So you can see that's the forward movement and the backward movement in the reverse of the foot pedal. To basically check if the microkeratome is working properly before you apply it to the patient. So what determines the flap? The blade speed should be good. It varies anyway in different microkeratomes between 7 and 14,000 RPM. The blade angle and sharpness is about 25 to 30 degrees. These are semi-planar flaps in the SBK. They are not exactly like a meniscal flap. Basically, a planar flap means that they are vertical side cuts. So a microkeratome, though it cannot achieve that, in the SBK it achieves a semi-planar flap. The maintenance of the IOP, like I said, is very important. There should be no downward or upward pressure of the surgeon's hand. A downward pressure would lead to a thick flap formation, and an upward pressure may lead to a thin flap or a suction loss. So ensure that you're not pressing down or up. Just a very loose control over the suction ring is necessary to ensure a smooth flap. Ensure a slight nasal show. Again, that's important because the hinge is on the nasal side in the SBK, and we don't want it to come too centrally because that will affect the way the ablation is done. How do we choose the right ring? So when we look at this, this is a chart. It looks very confusing. I'll just give you an example to show you the same. You have to look at the horizontal K values. If it's more than 15 degrees off from the horizontal, the flatter K, then you would look at the KM values. If the astigmatism is also greater than 2 diopters, then the KM would be looked at. For corneas, like I said, the white to white, if it's greater than 12, take the smaller ring. If it's less than 11, take the biggest of the 3 rings. And cornea between these, take the one in the middle. So this is an example of a pentacam at what to look at. So K1 in this is the horizontal K. K2 is 44.1 at 100 degrees. So that's a more vertical one. So at 41.2 at about 10 degrees would be the horizontal K, and the white to white is 11.5. Therefore, as per the normogram, we would take a ring size of 0 with a stop size of 8, and the flap diameter we would get is about 9.5 mm. These are just a couple of videos from my colleague, Dr. Aarti, just to show you how it looks from the outside. So this is the suction ring being applied to the patient's eye, and we check for whether the desired pressure has been obtained. The pupil would dilate slightly, and then you would see that it's holding on snugly. And this is how you align the microkeratome in place before you do the forward and then the backward pass. This is an intraoperative video of the Amadeus system. I'm just going through the steps. Marking is important, following which you would do the applanation to check whether the pressure is adequately obtained, the forward pass of the microkeratome, followed by the backward pass, after which the suction is removed and the patient can actually see the light again. The flap is lifted. This is the Vizec system, the excimer application happening, as you can see over there. At the end of the procedure, you use fluid to reposit the flap into place. Just make sure that you clean the flap so that there's no chance of DLK. Iron the flap out. The markings you should see are aligned properly so that there's no flap slippage. And the last thing is to check the gutter, make sure it's uniform all around. Coming to just the complications which are common, suction loss is a common thing in microkeratome LASIK. It's not as common as with femto because the suction is stronger. However, flat corneas, deep set eyes, narrow palpebral fissures, lid squeezing, and a change in the patient's position or sudden movement can lead to a suction loss. In a microkeratome LASIK, it's better to defer the surgery if this occurs. Buttonholing, like I told you, is a grave consequence. And the risk factors for this are steep cornea, a suction loss, thin flap, the power decrease in the microkeratome, and blade imperfections. If it's been reutilized, it's diagnosed while lifting the flap. You'll see an island left behind or a divot on the undersurface of the flap. You can see that circle over there. It denotes a hole in the flap. In these kind of cases, don't perform a laser ablation, defer the surgery, and do a surface ablation at a later date. For a free cap, it's the opposite case. So you have a flat cornea, a deep orbit or decentered improper suction. This is again diagnosed after the pass of the microkeratome. It is essential, therefore, in microkeratome LASIK to mark your flaps, because if you have a marking, you can align the free cap in the position that it came out. You apply a BCL after that, make sure the flap is aligned, and if needed, then you can suture it as well. Flap striae again are a side effect which sometimes occur, as you can see over here. I'll just skip through this video. The important steps in this include removing the epithelium. So if your flap striae are there for long, it's important to remove the epithelium, float the flap with a hypoosmolar solution, and then after that, iron the flap with the help of either 2 Mercier sponges or just like this, you can iron the flap. So macrostriae are due to misaligned flaps and are often cause visually significant symptoms. The causes are dryness that leads to shrinkage and misalignment and squeezing of the eyes. Like I mentioned, gently stroking the flap, lifting and repositioning it after removal of the central epithelium. Sometimes again, suturing the flap is necessary in these cases. And to prevent striae, like I mentioned earlier, marking the flap is critical. DLK is again a common complication. It's more again seen in intralaser LASIK or femto LASIK compared to keratome. It's a sterile inflammatory response, and treatment is with topical steroids. If it's if it reaches stage 3 or beyond, then relifting the flap and washing is necessary. Epithelial ingrowth again can occur if there's been an epithelial defect or a partial flap. You get a cluster of epithelial cells. It can cause a necrosis overlying it if it's not handled. If it's in the periphery, again, you do not need to specifically treat it, just observe it. If it is central and causing visual disturbances, then lift the flap, clean it with mitomycin or with ethanol, and then wash the flap. So these were just a few complications that I wanted to mention. I want to acknowledge some of the videos I took from Dr. Aarti and Dr. Dariel and Mr. Kaushal at Shroff Eye Center. Thank you.
Thank you, Dr. Usha. That was a really comprehensive talk. We would be having our next talk immediately on femto-LASIK. So just very briefly, if we could compare the flap of a microkeratome LASIK versus femtosecond, and then we can go on to how we go ahead with the femtosecond LASIK. Just a few points for the benefit of the PGs.
So should we do that after the presentation, ma'am, or just?
Yeah. Managa?
Yes.
We take the femto-LASIK and then take one comparative question.
Only thing is that I think normally you take a 8 millimeters flap. When do you make a 9 millimeter? For hyperopes, you would make a 9 millimeter.
Larger flap.
An astigmatic.
So that is there, but not much is asked as far as the technique of microkeratome is concerned, except for maybe the steps.
Any question? Anaga's question?
Just one comment about the meniscus and the planar flap. I just wanted to clarify, meniscus flap is what you get with the microkeratome, where it's thinner in the center and periphery is a little thicker, while with the femto laser, you get a more uniform flap thickness, and it's anatomy blind, where irrespective of the curvature or the thickness or the overall diameter, you get exactly what you need with the femto-LASIK. I thought Rushad mentioned slightly differently in his presentation when he talked about meniscus flap.
So he said
So it was the same thing, that it's not a, I mean, the periphery is a little thicker only.
Perfect.
What was mentioned. And the variability of the flap, that the thickness of the flap is much more in microkeratome and lesser in the femtosecond.
Yeah, so that is definitely there. I mean, there are advantages of the femto, which I
How
mean.
would you avoid a buttonhole or a free flap?
Ma'am, so selection criteria is the most important thing. So like I mentioned, don't go, at least for me, I stick between 42 and 46 diopters. Anything outside that range, I try to counsel the patient for a femto LASIK, or if it's a low diopter treatment, then a surface ablation. Steeper corneas would definitely be predisposed to buttonholing, whereas a flatter cornea can be predisposed to a free cap. So ensuring the suction is properly applied, maintained, ensuring that there's no decentered suction, all those things become important to avoid that. Again, in ensuring that you don't reuse blades too often. So that also, the speed of the motor or the way the blade translates through can cause these problems as well.
Yes, well answered, Rushad. Anaga, would you introduce the next speaker?
Sir wanted to ask something.
Yeah, just as Rushad, very nice talk.
Yeah.
One thing that you just mentioned about the variability of the thickness of the flap, like if a blade is reused, it becomes, the flap is a little thinner.
Yeah.
So that is one thing that, but however, in COVID times, the reusation of blade is absolutely something that is not to be done. And one blade for two eyes, means of the same patient, is all that we can do. And the other thing that you mentioned very well is about the free flap. And when a free flap occurs, what is to be done? That is important. And first and foremost, of course, the surgeon doesn't lose his cool, and the flap should be should be placed the right side up. And the best way to do it is not to lift the flap off the microkeratome, but to just slide it across and put it on the cornea and orient it with the markers in place. So a few small practical tips, and something to do with the complication, which is less in these days than it used to be in earlier days. And I think we all were used to the Hansatom at one point of time, which created a flap, a hinge superiorly. So that again was quite a blind procedure. Here with the microkeratome blade with a Moria, it is a transparent pass on, and thereby a surgeon, an experienced surgeon, can stop the pass of the microkeratome if he feels that it is going too much on the hinge side. So one or two things there.
Thank you, Partha. All very important inputs. Anaga, you'll introduce the next speaker.
So our next speaker is Dr. Sean Socrates de Silva. He is the center head of Bangalore Eye Foundation and the consultant to cataract, cornea, and refractive surgery. He is going to speak to us on femto LASIK. Yeah. Can you please start sharing?
Yeah. So thank you, Dr. Anaga, for that introduction, and I would like to thank Dr. Chitra also for including me. Has the slide sharing started?
Yeah, your screen is seen. Yeah, you can go on to play. Yeah.
Full screen.
A very good evening to all the panelists. And what I'll be talking about today is about femtoLASIK. And I think what femtolasers did to ophthalmology is what smartphones did to the mobile technology. The femtosecond laser is basically an infrared laser using 1053 nanometers wavelength with a very ultra short pulse duration of 10 raised to minus 15. And that's where the name comes as far as the femtosecond is concerned. It has a very high repetition rate ranging from 15 with the earlier machines to up to even 500 kilohertz and a spot size of 3 microns. So what exactly this achieves is a very small focused delivery of a laser energy at a very precise place in the cornea, producing very less collateral damage to the surrounding tissue and thereby minimizing the damage to the cornea.
Yes, Sean?
Is the slide?
It's
Is the
not.
slide moving? Yeah.
No,
The principle of femtosecond laser is photodisruption. Here, when the laser energy is delivered to the tissue, it is absorbed by the tissue and results in plasma formation. An expansion of this plasma creates cavitation bubbles, which separates the tissue plane. Hence, there's formation of carbon dioxide and water, and this helps in creating a very clean cleavage plane to lift the corneal flap. This is how the femto laser actually works on the eye. And you can see as the suction ring is applanated onto the corneal surface, you have the docking cone, and then the laser fires in FS200. This is a raster pattern where each of these laser beam is creating cavitation bubbles at a focused predetermined depth in the cornea. And this runs throughout the bed of the interface as well as the side cut for the lifting of the flap. There is a very precise engineering in this and a very defined line separation and spot separation between these laser pulses, which actually enables a very smooth interface. It minimizes the amount of interbridges and allows a very clean flap lift with minimal tissue damage and inflammation in the postoperative period. Another thing that we need to know is that most of these femtosecond lasers have a number attached to this. And it's very important to understand that the repetition rate or the rate of firing of these pulses is indicative of that. For example, for the femtosecond 200, it is around 200 kilohertz. Visumax is around 500 kilohertz. And with the Zymer, it goes to even up to 10 megahertz. The advantage with a higher firing rate is that a higher repetition rate produces a much lesser amount of pulse energy. This is much more softer to the cornea. There's lesser amount of heat production, and the procedure time is also much shortened. The femtosecond laser was approved by the FDA for LASIK flap creation in 2001. We started with the AMO IFS laser, which was 60 kilohertz laser, and then moved on to the Wavelight 200 and the Visumax 500. And now with the Zymer Femto LDV8, in addition to the corneal procedures, it also enables us to do a femtosecond assisted cataract surgery as well. So the main difference between this pulse energy, why are we looking at 10 raised to minus 15, is mainly because at a much lower pulse energy of a microsecond laser, the spot size is much larger. It has a very high pulse energy, and this produces a lot of collateral damage and heat in the cornea, which is extremely minimized by this ultra short duration pulse, a very low pulse energy, and a very high pulse frequency. This is how fast the laser is actually in the human eye. And this is a real-time video. I'll just forward it right up to the point of the laser delivery. Here, after the complete applanation occurs, the entire flap creation takes hardly around 40 seconds. It starts with the canal formation, and then the interface bubbles are being created. And once that is complete, you have the side cuts being created, and that's the end of it. It actually takes hardly around 7 seconds for completion of the flap. As we discussed earlier, as compared to the microkeratome, which created meniscus flaps, which were thinner in the center and thicker on the periphery, with the femtosecond laser, you have much planar flaps with a vertical or even an angled side cut. You can pre-program the depth at which you want the flap to be created. The predictability and safety is extremely good. And in several cases where you may want to avoid a corneal scar in the periphery, you can even reposition your hinge so that you do not get any vertical gas breakthrough. The flap centration is another advantage, that even after the docking, the machine would overlap the image of the flap onto the pupil. And if it is not centered on the pupil, you could move this a few millimeters to the left, right, above or below within the applanating ring. So that allows a lot of flexibility. Here again, the femtocanal plays a very important role. The femtocanal actually provides a pathway, and this is right before the flap dissection starts, for the excess amount of cavitation energy, the gas bubbles, to escape out of the flap rather than dissipate in the other stromal layers, giving rise to an OBL. A very smooth dissection allows a very easy lift of the flap, and it minimizes the interface bridges which may be created if you have excessive opaque bubble layer. Just mentioning about OBL in my next slide is that this is the most common occurrence in femtosecond lasers. It was much more often earlier with the lower repetition rate lasers with the AMO machines, but now with the Wavelight FS200, the Visumax, the OBLs are much lesser. Here, the gas bubbles actually dissect deeper above and below the intended plane, This gives rise to a lot of tissue bridges and may result a lot of difficulty in dissection. You'll have eye tracking problems because the tracker can no longer recognize the pupil, and sometimes you may have to keep the patient outside the operating room and bring him later once the OBL has reduced. So one of the ways to reduce OBL is, as seen over here, is that this is the laser plane in which the bubbles are being created. And this is the canal which connects the plane to the external area up to the limbus, allowing the gas to escape. And their studies, they found that keeping a denser canal line with a 2.5 spot separation and a wider canal width helped to reduce the OBL intraoperatively. So we've already gone through the complications of microkeratome, and here I think femtosecond laser has made it really life easier for us. We no longer have to worry about intraoperative problems like incomplete flaps, buttonholes, and intraoperatively, even if you have a suction loss, you can still continue, read off the patient and go ahead with it with the femtosecond laser in the flap creation. Postoperatively, epithelial ingrowth is minimized in femtosecond laser with a good side cut angle and a good flap adhesion in the periphery. In the earlier reports in 2010, we did have the femtosecond lasers producing a lot of diffuse lamellar keratitis, transient light sensitivity syndromes, and these were attributed to the laser causing collateral damage in the cornea with activation of the stromal keratocytes. Now with the newer lasers, the outcomes are equally comparable as far as very minimal postoperative inflammatory complications in the cornea. And with the recent comparison, the new femtosecond laser models allow much lower energy delivery to the cut flap, and the overall inflammatory response is not significantly different from the microkeratome. So in addition to all the intraoperative advantages it offers, postoperative complications are also minimized. Well, the complications which can occur intraoperatively are suction loss, incomplete flap, challenges in docking, OBL, as I showed earlier, iris recognition issues. But all of this can actually be managed. You can go ahead with a complete procedure on the same day, and you will not have to postpone the surgery or defer it for some other day. Postoperatively, we can still see a diffuse lamellar keratitis. This again is due to interface debris. If you have allowed too much of debris accumulating under the flap, or meibomian gland secretions, transient light sensitivity syndrome, and central toxic keratopathy. Again, diffuse lamellar keratitis, as covered by Dr. Shroff, is that the interface, it's an inflammatory condition where you have activation of the stromal keratocytes due to interface debris, while central toxic keratopathy is a non-inflammatory condition known to occur due to apoptosis of the stromal keratocytes. Again, flap folds and microstriae can occur in thin flaps and small hinges, and Dr. Shroff has covered this very elaborately. So the overall advantages of a femtolaser, you have fewer flap-related complications, the hinge position flexibility, a lower incidence of epithelial ingrowth, less variability in flap thickness, precise control of the flap diameter and hinge width. You can have a much larger flap diameter and hyperopes, improved visual outcomes. Thinner flaps, even up to 90 microns, can be feasible and highly predictable. Stronger flap adherence, probably due to the inflammation at the edge of the flap, less increase in intraocular pressure, less hemorrhage from the limbal vessels, and ability to retreat immediately, even if there is an incomplete femtosecond laser ablation. So I'll quickly run through this video. I have around 40 seconds remaining, just to show how easy it is to dock. Here down, you can see the interface being locked into the femtosecond device, and here you have the patient eye being locked in. It's a very user-friendly procedure. I'm working on the FS200, and once you have put the speculum in and allowed adequate scleral exposure on either side of the cornea, you allow the cone to dock onto the surface of the vacuum, and the laser would hardly take around 7 seconds to get completed. One advantage I may have not gone into details is about the double suction that is one of the safety mechanisms. So here you have the outer ring, and as you put the suction on, you'll have a green light coming up on suction 1. So once this turns green, then you dock with the central cone. This applanates the cornea. This allows the machine to calibrate at what depth the cavitation bubbles are going to form. And once the cone has applanated the cornea adequately, you can see that this entire area will be a zone of applanation, where you can clearly see on the monitor. And then once the suction 2 turns green, then you go ahead and fire the laser. Just another 20 seconds, ma'am, and the video is over. So the entire flap making would hardly take around 40 seconds, and the laser would go on for around 7 seconds for the actual completion of the flap. So we have a green suction 2 as well. This is where you can move this flap if it is not centered on the pupil. The canal length would be around 0.7 to 0.9 to ensure that it communicates with the limbus and we do not get too much of gas bubbles in the peripheral limbus or in the superior part of the cornea. So now we've started with the canal. You have the raster pattern. And once this completes the interface, you will have the side cut of the bed and the procedure is complete. Thank you very much, ma'am.
Thank you, Sean. That was a detailed talk. I wanted to ask the expert audience, what would you feel is the disadvantage of creating flaps as thin as 90 micron, or it doesn't stand to be a disadvantage at all? Dr. Sri Ganesh? It's not there? Anybody?
Yeah, one of the disadvantages of having a very thin flap is that there's a tendency for flap slippage and also micro wrinkles. And sometimes you may not be able to see the micro wrinkles on slit lamp, but if you dilate and do a retroillumination, you can see the fine micro wrinkles. The vision may be good. Patient may have 6/6 or better vision, but then they will have a lot of night vision problems like glare. And this is one of the problems. And also I find that flap slippage is very common because when you make a 90 micron flap, many of these, especially the intralace, has a standard deviation of 14 microns. So 90 minus 14 would be like around 70, 75 microns. And the epithelium is already about 50 microns, 50, 55 microns. And if there's some swelling of the epithelium, it can be thicker. So you just have the Bowman's and the epithelium and hardly any stroma. And the flap basically sticks back because of the zipper-like action of the mucopolysaccharides in the stroma. So you need some amount of stroma there for good flap opposition. And if this adequate stroma is not there in the flap and you just have the Bowman's and the epithelium there, then the flap does not stick back and has a tendency for slippage. So you can have more flap dislocations post-op. So I don't like to do very thin flaps. I like to at least keep 100 or 110 microns flap thickness.
Would you think these flaps there'll be more regression also when you're using thin flaps?
Regression may not be an issue. I mean, the biomechanics definitely is better, as shown by studies by John Marshall, where he has looked at flap thickness and then percentage loss of corneal strength. But then, of course, it has both its advantages and disadvantages. If you're using a very thin flap, I would suggest that you use a BCL post-op to prevent slippages.
Any other questions? Shall we go on to the next speaker? Anything relevant to be brought forth? Expert panel?
Yeah. Actually, I've been using the 90 micron flap for the intralace for now, I think 3 years over. So we initially, for the first 50 eyes, we checked on the ASOCT to, of course, the ASOCT is not a very, very accurate tool on that sense, but we got it more or less approximately 5 to 7 microns this way and that. So we stuck to the 90 microns and it has been more or less free of most of the complications of wrinkles or slippage, and it's worked quite well. However, it definitely needs, we do not use the BCL also, but definitely needs a good drying time and a good apposition, good apposition plus a good check on the slit lamp after the surgery is over. And though most of the excimer lasers come with the slit lamp attachment, but still we cross-check it once, approximately a half an hour after the procedure is done, just to ensure that the flap is well in position.
I think I tend to agree with Partha in the sense that one of my indications for using a femtosecond laser is to produce thin flaps, though theoretically 14 micron variation is possible, especially with the more advanced FS200 lasers and the Visumax, the variability is not so much. I would be very wary of creating a microkeratome flap thickness of 90 microns as is possible with the Moria, for reasons which Sri Ganesh explained so clearly, because you might get an extremely thin flap with very little stroma on it. But with the femtosecond laser, I would not hesitate to go ahead and get a 90 micron flap, because most often the variability is just in the range of about 5 microns. And the advantage is that you get a vertical side cut, or you can get more like a manual side cut. And positioning these flaps, not that slippage cannot occur, the tendency for them to slip is much less compared to a microkeratome flap.
No, but Ram, my question to you is, good evening, is that a standard of care for you to make 90 microns flap, or normally you make 110 or something like that?
Usually we make 100 microns, but whenever the thickness is a concern, then do not hesitate to go ahead and make a 90 micron flap. And it seems to work quite well. It's extremely rare for microkeratome flaps, more of microstriae, macrostriae, flap slippage and all used to happen. With these femtosecond flaps, we hardly ever come across that.
Yeah, so basically in our practice, normally I make 110 or 100 more 110. And in the cases where the thickness is a major issue, then maybe try 90, but otherwise switch over to surface ablation. So typically, yes, it's a case of making in the microkeratome, it came more as a bravado to say that a femto goes up to 90, so we can also do up to 90. But ultimately, a 90 flap is not as stable as a 110 flap would be. You have started, we have started, we all started with 160 and 180 flaps on the Hansatome. And we have come down. So I think the sweet spot for most of us, at least for me, is 100 and 110. So I don't really, it's only in very extreme cases that if we have to actually, that small window. Otherwise, if the thickness is much lower and the other parameters are there, then prefer to go on to surface ablation. And otherwise, there are some cases where we make 90, but those number of cases are in at least my practice less than 10%. It's not a standard of care for me to make 90. That's all that I want.
We don't normally aim at 90, but with the femtosecond laser, do not hesitate to use it if it's indicated.
Yes.
And,
okay. One last question. If you were to do a PRK enhancement on these very thin flaps, what is the challenge which you would face in these eyes? Yes, go ahead.
Haze would be a major factor in thinner flaps, because you're very, there'll be a lot of microstriae, like Dr. Sri Ganesh said. And when you laser hits the thing, so your need of mitomycin has to be longer.
Yes.
And, you can't keep the same traditional 10 seconds or whatever. Yes. And if you're keeping low power, and preferably manual removal would again create a lot of micro trauma. So laser-based PTK would be a better option. And longer use of steroid, maybe stronger steroids like PRED for at least first 4 weeks, because haze is a major factor, because wound healing would be different, because your flap is going to be 80% covered by epithelium itself.
Thank you.
The concern for me with a thin flap enhancement on the flap would be, if you have just about 20-30 microns of stromal tissue and you have debrided the epithelium and you're correcting about a couple of diopters, which is not too common when you're doing enhancement, then you could go right through the flap onto the stroma, which may not be a good thing as far as the results are concerned, as well as the propensity for haze.
Good. This is what I wanted, a discussion on thin flap, and it's been well covered. So we shall now go on to our next speaker, who's none other than our charming Dr. Rupal Shah from Baroda, who's the center head of the Baroda group of CFS, who has also been one of the very eminent leading initiators of SMILE at a global level. And she's going to be talking on Relux SMILE technological update. On to you, Dr. Rupal.
Thank you, Dr. Chitra. Am I audible and visible?
Yeah. Always visible.
So thank you very much for this invitation, and I'm really glad to be here. A small note for the PGs who are attending this, please don't get swamped. I know this is a lot of information that you're getting from the experts on the field, but don't get afraid, because it's not everything that you're going to be able to memorize or remember from everything that everybody is talking. Just try to listen, try to understand, try to take some notes and some points which will sound very familiar when you go ahead and read about it. It's all there in the literature. Nothing that we are speaking here is not there. It's just that what we are trying to do is put things in perspective so that you will be able to learn better. Having said that, I'm also saying that please don't learn just for the sake of passing this particular exam. Learn because it's going to help you for your life and your career and your practice. Also help you to decide what you want to do in life. So please learn rather than just trying to memorize everything. And that will make you also not get swamped and apprehensive about so much information that's getting thrown at you right now. So I'm going to be talking to you about SMILE update. And I have been a consultant for Carl Zeiss for developing this particular technique. For people who don't know what SMILE stands for, SMILE stands for small incision lenticule extraction.
You have not shared your screen, Rupal.
I have not. I did share it. Okay, I'm so sorry. I'll just try and do that. Is it happening?
No.
Now can you see?
No.
No? I don't know how it's not happening.
Would you like to start sharing again?
Yeah, I'll just do that. I'll just start sharing it again. Just 1 minute. Is it seen now?
Yes, yes, yes. We are seeing your screen.
So I'll just make it full. Is it full screen?
Yes, yes.
Okay, so I'll just go ahead. SMILE stands for small incision lenticule extraction. It's the latest way in which one can also perform corneal refractive surgery. How is it different from the other procedures that we learned so far? Here in SMILE, it involves not ablating of the corneal tissue, where it's just like evaporation that is happening from the corneal surface after creating a flap or after removing the epithelium. As against that, in SMILE, what we do is to carve out a lenticule from within the cornea, which is intact. So we make use of only the femtosecond laser. No excimer laser is used here. The femtosecond laser is used to make one pass which is more posterior. It separates the posterior part of the cornea from the lenticule. And this is followed by a second pass which is more anterior. This forms a lenticule within the cornea, which then can be removed through a very small incision, which is again made by the femtosecond laser itself. The dimension and shape of the lenticule conform to the refractive error that you want to create. So I'll just quickly show you a small video. Here you'll see that the way in this femtosecond laser is scanning is a little different. This is not the raster pattern that you saw in the previous talk. Here, it's a concentric way in which the femtosecond laser shots are fired. This is the first pass that got finished. It is followed by a side cut. The second pass is more anterior, and it is then followed by a small incision, as you can see here. Now, right now, this particular procedure can be done only with the femtosecond laser, which is from Carl Zeiss company, which is known as VisuMax. Once you have the small incision, you open it, find both the planes, and then with a blunt instrument, go ahead. Right now, I'm going above the lenticule, separating the upper part, which is above the lenticule, which forms a cap. And now I'm beneath the lenticule, separating the second layer, this blue one that you can see on the side here. So you can imagine that this whole lenticule is now free of any adhesions above and below. So you can just grasp it and remove it through the small incision, leaving the cornea smiling back at you. Now, what is the advantage of this particular procedure? But before that, let us know the timeline. So it was way back in 2006 that the first 250 eyes were done in Germany. And the first results show that the procedure was feasible, it was accurate, but the vision recovery was a little too slow. And we are proud to say that it was in the Vadodara Center in India, at the Center for Sight, that we treated the next 1,000 eyes, suggested changes, and got this opportunity to be a part of the development of SMILE procedure. So this is how it happened. What is important to remember is that the US FDA approval has also gone through for this particular procedure in 2016. And the first commercial sales of this particular laser and the technique happened in 2010, which means we are 10 years into the procedure now, for which this is commercially available. So it is becoming very fast a procedure of choice. And this is because of the remarkable aspects of SMILE, which is the predictability, accuracy, and stability of treatment. This is the aspect of SMILE which has changed only a very little since our very first study, even though now we have many aspects of the treatment which has changed. Now there are better energy and spot parameters, different scanning pattern, higher frequency, better surgical technique, better instrumentation. But right from the beginning, we found that more than 98% of all eyes are within plus or minus 0.5 diopters of intended correction. And this is borne out by several studies done across the world, as you can see here. Now, why does this happen? This happens because here we do corneal reshaping without photoablation. What an excimer laser does is it performs photoablation, the rate of which increases linearly with fluence beyond a certain threshold, which means if the fluence increases, the photoablation rate increases. This results in a scatter, especially for the treatment of high myopia. Also, the excimer laser is getting affected by a lot of factors, including the depth at which it is working, the corneal hydration, the humidity in the area, if there are fumes in the area, and this all can result in the scatter in the treatment and therefore there was a need for something which would give you a more predictable result. SMILE uses cutting instead of ablation with much less influence of any external factors, and it's a binary process instead of a linear one, so either it cuts or it doesn't cut, and when it cuts very precisely. And therefore, you would find that the results are very, very predictable. As regards inflammation, the total amount of energy input into the eye with SMILE is less than with femto-LASIK even. And this results in less inflammation and therefore a very high stability of treatment. There was also a very nice study which was done in Singapore, which showed that at any depth of the SMILE procedure, you would have the same amount of inflammation as compared to excimer use, laser use, where if you have a smaller depth, you would have less inflammation. At a deeper depth, you would have much more inflammation. So you can imagine that for the SMILE procedure, the results are going to be predictable, whatever depth or whatever amount of refractive error you are trying to treat. And this is borne by many studies. This is one of our own, where we showed that even at 9 months, the safety, if you compare femto-LASIK results, so we did in 25 patients of high myopia, one eye femto-LASIK, the other eye SMILE, and we found that the results were much safer when you are using SMILE as compared to femto-LASIK, and the results were also more stable, as you can see here. And the difference in stability between the two procedures, so mind you, these are contralateralized studies where there is a head-on comparison. And it was found that it was statistically significant over a period of 9 months. As regards efficacy, we found that the EDTRS letters uncorrected visual acuity was much more when we were doing SMILE instead of femto-LASIK. And this is also shown that the induced aberrations that would happen are much less. And because you are carving out a lenticule, you are not going to have any peripheral losses in fluence, which would happen with an excimer laser. And therefore, you would find that the induced aberrations are much less, and the results therefore are much better. As you can see here, you can see the right eye has been treated with SMILE, the left eye with femtoLASIK, and the point spread function is much better in the SMILE eye. If you compare the image simulation, again, the SMILE eye, which is the left eye in this case, has done much better. And if you compare the zone, you would find that the SMILE eyes form the actual zone that you have intended them to be performing. And therefore, you could get away with a slightly smaller optical zone if you have tissues which is less. If you are going to do SMILE as compared to femtoLASIK, and therefore you would still have a more stable and a better outcome with less induced aberration. Long-term data, we have been studying 10 years follow-up data at our center now, and we've seen the trend that it shows remarkable efficacy, safety, and predictability, and it truly is a paradigm shift in refractive surgery. The surgical ease is definitely there because you are using only one laser instead of two, but you do need to learn the technique better because it is also more surgically involved than probably say a PRK technique is. What about biomechanics? It's been assumed and also proven mathematically that SMILE, because it spares the more anterior part of the stromal lamellae, would show a better biomechanics. But till today, it is still proven that the surface ablation still scores higher as compared to any other corneal refractive procedures. As regards dry eyes, you can imagine that you're cutting out less nerve endings, and also it's a self-sealing smaller incision, and therefore the dry eye profile is definitely better in case of SMILE as compared to other corneal refractive surgery. And the other advantages of SMILE is that there is no flap, and therefore no flap-related issue. Less dry eyes, better patient workflow, and it is also very lucrative for a patient to choose such a procedure which is painless, bladeless, flapless, and which can give you a quick recovery, and you can practically go back to work. Within a week, you can go scuba diving and there is nothing which is going to change there. Coming advances in SMILE, there are going to be newer lasers from many more manufacturers. The possibility of hyperopic treatments is just around the corner. Presbyopic treatments are going to get studied. Cyclotorsional adjustment, which may be an advance in SMILE, and we would now have faster lasers with almost free-floating lenticles, which would make the surgical technique also more reliable and easy. So in conclusion, it's a remarkable technique showing remarkable stability, predictability, and safety. And it's likely to be the technique of choice for refractive surgery in the coming decade. And so you must also know about this particular option and keep it in mind. The excimer laser is still not obsolete. You are going to need it for treating hyperopia, for doing retreatments. For retreatments after SMILE, you can either do it as a surface ablation over the cap, which is not a flap, it's a cap, or you could use a special software called the Circle software, which converts the cap into a flap, which you can open as a flap of the femto laser and use your excimer laser on the bed of the stroma and then put the flap back. Or if you have done if you've done a thick cap, then you could make a thin flap out of a made with a femtosecond laser from the cap and use again your excimer laser on the bed. Customized ablation is not right now possible, but it is required in a very few patients in virgin eyes, and it is also the place where you need to use your excimer laser. Thank you very much. I would really appreciate questions if there are any.
Yeah, there could be a lot of questions, but I think we are a little running short of time. So we'll keep some of these questions for the end based on how it goes. I'm going to go on to our next speaker. Our next speaker is a very popular public prosecutor, chairman and MD of BBI Foundation, Calcutta, and the ever charming scientific committee chairman of AIOS, who's going to talk on his favorite topic, phakic IOLs, the essentials. We could keep a question in our minds for SMILE and the future topics as it goes on.
Thank you very much, Chitra, for this kind invitation to a very, very popular course that you are carrying on with the ARC team. Kudos to you and to your wonderful team. Wonderful talks we have had throughout the evening, and to chip in with phakic IOLs, the essentials, and I'll try to keep it as basic as possible so that we can think about the essentials of the phakic IOL and what it is there for refractive surgery. So refractive surgery is in two compartments, the laser refractive surgery and the non-laser refractive surgery, in which the phakic IOL holds a huge promise and is taking up a large share of the refractive surgery as of today. So we have the ICLs and the other phakic IOLs in the Indian market, and they are being well used in the market, and we need to know about them. So the ICL or the toric ICL, these are foldable lenses, and they are posterior chamber sulcus located lenses. And it's a place that the location itself is a location which is stable and relatively atraumatic. Now, the ICL is made up of a particular copolymer, and it's a collamer lens with collagen and hemapolymer copolymer. And this has stood the test of time due to its excellent biocompatibility, excellent transmittance, and low reflectance patterns. And they are extremely flexible, foldable, and a very small incision is required to inject it. And the best part of it is also easily removable. Thereby, it becomes a surgery which can be reversed as well. So about the concept of the posterior chamber, and that's a very important concept for us, that is behind the iris. Now, why is it an important concept? Because this phakic IOL is going to stay in the eye of a, say, 20-year-old for the next 40 years, maybe, or more. So it has to be in a position that must stand the test of time. So this is far behind the endothelium. It is excellent in cosmesis and very close to the nodal points of the eye. The gain in the retinal size of the image is remarkable, and thereby a patient who is wearing, say, -10 or 12 or -14 diopters of glasses and is very dependent on contact lenses, he gets a wonderful feeling of not having to wear his glasses or his contact lenses, and thereby going about his or her normal activities. And the retinal size of the image is one very important factor that comes into focus. So the effective optical zone is also greater, and the sulcus in itself is a very stable location, and as we said, that it is easily removable and exchangeable. And the phakic IOLs, or the few of the first ones that came into the market were the artisan lenses or the very sized lenses, and they were iris clip lenses. And thereby it was fixed to the iris tissue in the anterior chamber. But over the years, there were problems with these lenses, and there was corneal decompensation in some of these lenses, though a stringent anterior chamber depth was kept for these lenses to be implanted. The lenses at times, the claws or the fixation, they gave way, and the lenses at times fell into the anterior chamber, and thereby creating a lot of problem both for the corneal endothelium as well as for the visibility. Whereas this posterior chamber lens of the ICL or the IPCL and the other posterior chamber located lenses do not have this difficulty, and it does not either alter the shape or it does not remove tissue, and thereby the pristine cornea is intact. And again, if we look at some amount of time when this patient would develop cataract, the calculations of the biometry in a post-LASIK or a post-refractive surgery done eye is definitely a lot of challenge. Whereas in such cases, in the ICL or in the IPCL or in a phakic IOL patient, the biometry, it is not a challenge, and the biometry is the same biometry principles that we adhere to in a phakic lens. Now, the design and the features and the availability, the myopia and the myopic astigmatism can be done. And I would like to speak upon the ICL, which comes in the range of -3 to -23 diopters. And this is both for the myopia and also for the toric lenses. And for the toric lenses, the cylinder power that can be corrected would be up to +6 diopters of cylinder power. The V4C, that is the developed, that is the ICL that has been well developed, and it has a central port, and this central port is a very important part in which the circulation of the aqueous is unhindered, and thereby it protects the lens, the crystalline lens, to an effect. And this has been a very, very important manufacturing strategy for these lenses. And these, the central port is 360 microns in diameter, and it is such that it does not create aberrations in the visual effect of the patient. And this V4C with the central port is available for myopic spheric and the myopic toric lens versions. Of course, in the hyperopic versions, the central port is not there. Why not there is a very important question which an examiner at times asks. And the answer is very simple, because the hyperopic lenses are thicker than the myopic lenses, and a 360 micron of aqua port or the central port would create aberrations in these lenses. Therefore, the corollary to this question is, so in which cases of the present day ICL is a PI mandatory, is a peripheral iridotomy or iridectomy mandatory? It is in these hyperopic lenses that it becomes mandatory. So the prerequisites of phakic IOL, the crystalline lens has to be absolutely clear. The patient should have refractive error which is stable for at least 6 months to 1 year, and definitely less than 0.5 diopters of change. We do not stick to this 18 years figure all the time, but what is important is the stability of the refractive error, and that is important because the same optometrist or the same physician or the same ophthalmologist should have checked the power of the refractive error of the eye before going on to phakic IOLs. Ametropia, and obviously that which is not suitable for excimer laser surgery. However, as we just discussed, the number of patients for phakic IOL is becoming larger and larger because of the stringent protocols that are being followed for the excimer laser surgery. Unsatisfactory patients are intolerant to contact lenses or spectacles. And again, when the initial corneal thickness is less than 480 microns. And LASIK in that particular eye will leave behind less than 300 microns of the residual bed. So this 300 microns is one figure that is again variable for different ophthalmologists, but by and large, the higher the dioptric correction to be done, the more the residual bed should be left behind. Therefore, that again becomes an important protocol in the excimer laser corrections. The other prerequisites are, of course, the anterior chamber length and depth, and that has to be greater than 3.2 millimeters if it is one of these iris claw lenses or the angle supported. Not much in use now. 2.8 millimeters for the posterior chamber IOLs. Again, another favorite question is, so what is the depth and from where is it measured? So it is the endothelium, corneal endothelium to the anterior, the capsular depth that is to be measured, not from the epithelium. The endothelial cell density is important, and we have a tabulation for the endothelial cell density, which is appropriate. Pathology of the eye, such as corneal disorders or glaucoma or uveitis of maculopathy, are contraindications. And the ocular examination is very important. Discontinuation of contact lenses at least 1 to 2 weeks, and especially if it is an RGP lens, definitely 2 weeks before the refractive error is ascertained. The refraction, the uncorrected and the best corrected visual acuity is important. Again, it is suffice to say that the best corrected visual acuity with spectacles usually increases, usually improves after a phakic IOL, and a binocular assessment is also important. The anterior segment evaluation, the pupil and the pupillary aperture is important. Again, a large pupil would mean, and the patient should be cautioned that there might be some amount of glare post-operatively, which usually comes down. The anterior chamber configuration and the iris topography and the iridocorneal angle estimation is also important, corneal and lens evaluation, and the measurements of the angle, the anterior chamber depth, the white to white, and the axial length, the intraocular pressure, and the gaze. The dilated slit lamp and ophthalmoscopy evaluation is important, and any peripheral lesions must be treated before doing and phakic IOL. So let's look at the more important parts of the investigations which we need to do, the white to white. And the white to white with the caliper is what must be done. And this caliper should again be well calibrated. It should be a digital caliper, and the eye should be treated with pre-anesthetic drops, and it should be measured under the microscope, the patient in supine position, and the caliper should be read either on the ruler or it should be read right on the scale that is given with the caliper. The anterior chamber depth is important and is defined a bit as the depth between the corneal endothelium and the anterior crystalline lens. It does not include the ACD measurement, and it's important to sorry for that. So what are the tools in which we look at the anterior chamber depth? And it's important because not all the tools give the right values. When we are looking at the white to white, the OBSCAN provides a very reliable value, and this should match between the two eyes, which is again very important. Unless there is some amount of pigmentation or some artifact on the sclera, and the mismatch is there but can be accounted for. So the IOL value of the IOL master, the white to white value by the IOL master, again shows two large values, and they are not comparable to the OBSCAN or to the caliper. But this is something that we can remember, and both the values with the caliper as well as the IOL master may be taken to ascertain that that difference is very much there and is there in both eyes symmetrically. So if one takes the white to white value by the IOL master, it can lead to an oversizing of the lens. Now the ICL vault is the most important because it is going to be there in the posterior chamber and very close to the anterior, very close to the crystalline lens, and the vault should be just about 250 microns to 750 microns, and that is the range of the vault. And that measure again is a very important question. How do you measure the vault by slit lamp? Well, it is half of the corneal thickness to 1.5 times the corneal thickness is the correct answer, and again a very favorite question for the examiner to ask. If it is an undersized ICL, it increases the risk of the anterior capsular opacification, which can lead to cataract and which can progress. An oversized ICL and is more than 1 millimeter or 1,000 microns may push the iris forward and the close to the angles which could lead to an intraocular power rise. So the ICL, or the toric ICL power calculation software, is available and it calculates very well. The preparation for the ICL, the toric ICL, is important. Again, the horizontal axis of this can be marked by the slit lamp, and this marking is important. Just an eye estimation might not be so accurate, and there are different devices. The bubble marker also can be used for the marking of the 0, 180 degrees. Now let's look at the procedure, which is the most important part. The most important part of the procedure is loading of the ICL, and that's a step that has to be taken with a great amount of caution. So this is the ICL which is in BSS, and this ICL of the V4C does not increase in size after the placement inside the anterior chamber. And it's first placed on the cartridge and the hub, and this hub contains methyl cellulose and some half of BSS, and it is pulled into the nozzle. And once it is pulled, it's very important to see that I'm going to stop here just to show that it must be, the ports must be totally vertical, and it should be seen under the microscope before and the ICL enters into the anterior chamber. So the anterior chamber is filled with either methyl cellulose or with helon, and the insertion is very important. Side ports are made, and the manipulation of the lens inside is very important. And so we'll just look into this video, which shows that the methyl cellulose is filling in, but it is just about optimal fill that has to be done. And this optimal fill is important so that there is just enough of methyl cellulose and the ICL opens the correct way, because if it does not open the correct way, then it's an upside down ICL which comes in with a lot of difficulty, and this has to be removed, and again it has to be placed the right side on. So the 3.2 millimeters incision is made, and it's important for beginners to put the nozzle inside the anterior chamber and to see the unfolding of the ICL, and it should fold the right side up, and the leading haptic should bear that hole, and it's important to see the leading haptic going in onto the pupil. The ICL should not plunge in the sulcus immediately, and the foot plates are gradually placed in the sulcus by the manipulator very atraumatically. And once that is done, then the removal of the viscoelastic is important. Here, either if it is helon, it comes out in bulk, or if it is methyl cellulose, it has to be removed very gently. And the amount of viscoelastic left behind, there at times is a little bit of viscoelastic left behind, but should be as minimal as possible. So these are the post-operative pictures, and usually the patient reads the best corrected visual acuity, and it is usually there is hardly any complaint of glare and halo, but a few patients might complain. And a 2-hour post-operative examination to check the intraocular pressure. If there is intraocular IOP elevation, it most likely is because of the retained viscoelastic. We do not do iridotomies in most of these cases, as we just discussed. And if it is, of course, done, then the PIs should be checked. The ICL vault is also something that needs to be checked. A quick word about the complications. The preoperative power, sizing, everything must be checked and cross-checked and double-checked and check 3 times before an ICL is implanted, because there have been instances where a wrong ICL has gone in, which has to be removed and replaced again. The wound construction is important because, again, these are young patients, they might squeeze, and a shallowing of the anterior chamber is something that is not required. Loading of the ICL, as we just mentioned, is very important. Insertion of the ICL has to be atraumatic, and if there is trauma on the anterior capsule, that can lead to an anterior subcapsular cataract. The early postoperative elevated intraocular pressure must be determined and can cause a drop in the vision. Traumatic cataract, of course, is something of a rarity. Late postoperative glare and halo and iris transim illumination defects might occur. Cataract and glaucoma are possibilities. Glaucoma, again, because these are high myopes and can come up with glaucoma at any point of time, so they have to be kept under check at least after every 6 months to a year. Long-term findings, pupil ovalization, very, very rare, and pigment on the lens or oversized ICL, again, is quite a rarity. A few words about the IPCL. Now, this is a
running short of time, Partha.
Yes, I'll just wind up in 1 minute. Hybrid hydrophilic acrylic material, and it comes customized, and the range is huge, -1 to -30 diopters, or +1 to +15 diopters. And the IPCL has design, and it can be implanted right transversely 0-180 degrees, even though it might have a toric variety, and it has a huge economic advantage, and customization of the IPCL can take place. The disadvantages need for a PI, and there have been comparative analysis and which show that both the ICL and the IPCL are very, very good and effective. Thank you very much, and thanks once again to Team ARC for the opportunity.
That was a superb talk, Partha, very informative. But I think, why would you need to do a PI for an IPCL?
PI for an IPCL?
Current model doesn't.
New model, we don't.
Models have all the opening.
It has the central hole.
Only one thing I would like to clarify, that for the age, I think Partha, of course, we are doing, I mean, people are doing for less than 18 years, but as per the FDA, the age for ICL that is approved is more than 21 years. And for the other procedures, it is less than 18 years. For LASIK, it is less than 18 years.
Thanks, Namrata. Anaga, can you introduce the next speaker? I wish we could have had more discussion, so much to ask, but I think we're really running late.
Yes, ma'am. So our next speaker is Dr. Sharon D'Souza, a very charming personality and one of the young torchbearers from the NN group of hospitals. She's a cornea and refractive surgeon, and she'll be speaking on CXL with laser vision correction.
Thank you very much. I hope my slides are visible. Yeah. Good evening, everyone. At the outset, I really have to say a heartfelt thanks to Dr. Chitra Ramamurthy ma'am and ARC and AIOS for this wonderful opportunity to speak among stalwarts. Now, this topic today, which I've been given, is not a very usual topic for postgraduate students. But then, of course, nowadays, a lot of their questions are with the new advances. It's quite a short topic, and I'll just be highlighting a few points which would help with their basic idea. So the topic covers some basic background information, what is extra, indications, the surgical procedure, the post-op care, how to choose the procedure, and how to evaluate outcomes. And I hope at the end of it, the students gather some information and don't fall asleep. So ectasia is one of our most dreaded complications of any refractive procedure, and it really spoils our Zen moment when a patient post-operative would come back with something like that. We all know that there is something called the Randleman's criteria, and for the benefit of the postgraduate students, it's a very beautifully written paper, although a long time ago, on what are the criteria which you look at in a topography, which has been discussed by our previous speakers, about how to identify an ectasia, even an early ectasia, and other features like what is the residual stromal bed that is ideal for if you're planning a LASIK, what is the age cutoff, what is the refractive cutoff for these patients. Now, but in spite of keeping all these criteria, we do come across patients who develop an ectasia. And there's been a lot of literature and, of course, experience around the world. And we now know that it is definitely a possibility among all the refractive procedures. So then what else can we do to try and avoid the ectasia? Of course, there are a lot of unknown factors that are there. And in spite of all precautions, we may have some post-operative surprises. So that is where the extra procedure comes in. Now, at this stage, I just wanted to clarify some terminologies because I have found that sometimes there's a little bit of confusion between these two topics. And as Dr. Chitra had very beautifully elucidated in her talk, topo-guided PRK with cross-linking is a procedure which we do for keratoconic eyes, usually early keratoconus, and it's used in addition to the cross-linking procedure to make the cornea more regular. An extra procedure, on the other hand, is a normal cornea with some suspicion which does not fit into an actual ectasia. So to make it simple, a topo-guided PRK with cross-linking would be a partial or a small amount of refractive correction with a full cross-linking, whereas an extra procedure is usually the full refractive correction with a small amount of cross-linking or a flash cross-linking. So the extra procedures are, they have been touted to potentially strengthen the cornea. This is by creating a little bit of scarring, little bit of cross-linking in the cornea, which appears like a pseudo-Bowman's layer. And it allows for treatment of patients who we may not ideally find fit for our regular refractive procedures. So who can we do this procedure on, or what are the indications for the extra procedure? And this is what we usually look at. So I've tried to simplify it into a sort of a scoring system. Of course, the topography is the first point that we look at. And since pentacam is something which is quite commonly read and even available to the postgraduates, the posterior elevations or an irregular topography, so posterior elevation not going into your ectasia range, but slightly suspicious. We also talked about biomechanics in our previous talks, and biomechanics again would be something which you take into consideration to plan and something like an extra procedure. So depending on which kind of biomechanical tool you use, deformation amplitude, or the ones which are combined with the topography, you could look at the parameters like the BAD-D, the CBI, TBI. So when you have certain parameters which are becoming suspicious, then we go forward to look at things like their age, what is the degree of refractive correction that is required. If it's a very high refractive correction, do we need, is the residual stromal bed too low? And what is percentage tissue ablation? So for people, for the postgraduates who are listening, percentage tissue ablation is calculated by taking the thickness of the flap, what is the thickness of ablation that how much the tissue ablation, divided by the pachymetry which you had preoperatively. So usually we say we shouldn't go more than around 40% of percentage tissue ablation. So in this 10-point scoring system, if you have more than 5 things, and this is just an arbitrary number as of now, but we are doing studies on it. If you have a lot of risk factors coming in, then either you should, look at why that's there or think of doing something like an extra procedure. Now, how do we do it? I don't have any financial interest in this talk, but what we use is the Avidro system, and that has a riboflavin called the Vibex Extra, which we use for this procedure. So very simply put, you do the regular refractive procedure, whether it's LASIK, SMILE, or PRK. After doing the excimer ablation, we apply the riboflavin. There's a 90-second soak of the solution, followed by a short duration of cross-linking, which is at a higher fluence, that's 45 milliwatts per centimeter squared for again 90 seconds. For the postgraduates, please remember our normal classic Dresden protocol, it's 3 milliwatts per centimeter squared for 30 minutes. But of course, now we have a lot of accelerated protocols which are available, as was discussed, at 9 milliwatts for 10 minutes and so forth. After this, the solution is washed off, and you, if required, place a BCL depending on what is the procedure. So there's a slight change in how we do the regular cross-linking versus the cross-linking which we do in the extra procedure. If it's a PRK procedure and you're planning for mitomycin C, you can still go ahead and use the mitomycin C, but of course the same precautions of washing it off thoroughly is also required. What do we check for post-operatively? Because it's a cross-linking procedure, we do know that there can be some amount of stromal haze that we see. Now, the cross-linking which we're doing is already slightly deeper because it's post the ablation or within the flap or within the smile cap. So it's a deeper cross-linking, but the penetration of the cross-linking itself is less than what we are used to seeing in a normal cross-linking. So don't expect like a deep demarcation line that we see. An early post-operative haze is expected. Keep a close watch on it and also on the intraocular pressure because sometimes it may give a false reading. So this is very important in the early post-operative reading. Before I come to the case example, the post-operative medications or treatment don't change. It's part of our routine post-operative. You do need an antibiotic usually 4 times a day for at least a week and tapering steroids over 4 to 6 weeks depending on how the patient is doing. Also a lubricant, and if you're suspecting that they may have increased inflammation, then you can use cyclosporin for 3 to 6 months at 0.05%. So just to give an example of what are the kind of patients that we look at for an extra procedure, this is a patient. After Dr. Sahil's talk, I'm sure this might be quite easy for you all to read, but it's a patient who has a topography. This is the Pentacam 4 map refractive, and everything falls into a normal pachy, normal anterior and posterior elevation, just the central little bit of, a bump there, but otherwise fairly normal. When you come to the Bellin-Ambrosio map, it gets a little more tricky because here a few of the indices have started looking yellow. And these are the indices that we usually look at and slight amount of posterior elevation. The other eye also has a similar picture. So here, when we look at the biomechanical indices, we do find that again, multiple of them are going into a yellow or a red, which becomes a suspicious cornea. This is just one topography. You could use whichever that is available to you. But so because there were multiple, indices which showed a suspicion, we decided that this patient may benefit from an extra procedure. So which surgical procedure, if we had to do an extra, then you have to combine it with a refractive procedure, which surgical procedure would benefit and how can we assess the effect? Now we have done studies to show that between the LASIK and the SMILE, once you cut into the cornea, there is some amount of biomechanical change. So when we know that a procedure could cause more of a biomechanical weakening, it would probably be better to, or may not be as beneficial to combine it with an extra procedure. So in that terms, maybe a SMILE procedure, which has lesser amount of cut into the cornea, because we are cutting less collagen fibers in small incision, may be more useful. And of course, with a PRK, there is no cutting of the fibers at all. So yes, I'm concluding. No cutting of fibers at all, so it might be helpful. Another way, if you had to talk about the future, and this has been covered before, so I won't spend much time, is to, of course, look directly at the collagen. And I hope in future, it might be, one of the modalities that are easier. But if you see the arrangement of collagen post the SMILE extra, this is before and this is post, it does seem to get a little more well coalesced and compact. So possibly there could be a stiffening or a strengthening there. And of course, the best way would be if we knew preoperatively itself who could or could not develop an ectasia. We're getting there slowly, but till then, at least thankfully, we have certain procedures which may help. Thank you very much. I hope that was useful to you.
Thanks, Sharon. You couldn't have done a better job than what you did. It was wonderful. There could have been good discussions, but let's hear Shreyas. Anaga, introduce him before we try one odd questions because good topics are here, the last few.
Yeah, we have with us here Dr. Shreyas Ramamurthy, another young leader who is a consultant cataract, cornea and refractive surgery from the Eye Foundation group of hospitals. He is going to speak to us on intracorneal ring segments, how and where. Yeah, can you please start your share?
Thank you so much, madam, and I thank everyone at ARC for having me over. As far as postgraduate teaching goes, somehow in intracorneal ring segments, not much has changed in 10 years. And but still, it's a kind of a favorite theory question to be asked in latest or recent advances part of the paper. And I hope the postgraduates find it useful. So the way I'm going to approach this talk is to talk to you briefly about the mechanism, take you all through how we do the procedure and the planning which goes behind it, very briefly share some results, how we combine it with other techniques, and some complications as well to finish up with. So the ICRS is nothing but PMMA segments, and what they generally do is just flatten the central cornea. So the original indication for which intracorneal ring segments was made was for myopia. But after the advent of excimer lasers and reliable excimer lasers, this then shifted on to treating ectatic corneas like keratoconus, PMCD, and post-LASIK ectasia. A prerequisite is to, however, have a central clear cornea. Whenever you have scarring, apical scarring, you're better off doing a DALK than doing an INTAX. Again, patients who are not very tolerant to contact lenses would benefit from INTAX, as we must remember that in keratoconus, contact lens continues to remain the best treatment option. Generally, we use between a keratometry of 46 to 60 diopters. Beyond 60 also we've done few cases, but the amount of benefit that the patient gets from the procedure is a little limited. As far as pachymetry goes, you need about 450 micron thickness at the 6 millimeter zone or at the zone of implantation. BCVA, generally patients who have very good BCVA do well with just spectacles and cross-linking, or you could do a more recent topography guided ablation. Patients with a slightly lower vision, somewhere between 612 to 624 or 636, would benefit from INTAX. Anything less than 636, you're better off either fitting them with a scleral contact lens or doing a DALK procedure. These are just rough guidelines and not written in stone. Now, how does INTAX work? So INTAX, what it basically does is it acts like a tissue spacer, as a passive spacer, where it is actually increasing the space at this area, causing a kind of like a mid-peripheral bump here. And by causing this mid-peripheral bump, it is flattening the central cornea. And by flattening the central cornea, and we are able to bring down the spherical equivalent. And also by using different ring segments, as I will talk to you all in the subsequent slides, you can also alter the cylindrical effect as well. So there are different types of rings available. INTAX, Kera ring, Ferrara ring, and Mayo ring are the ones which are commercially available. I will restrict most of the talk to INTAX, but the other ring which is commonly used is the Kera ring. Now the Kera ring is available in a wide range of arc length. INTAX previously was available only as a 150-degree arc length segment. Now you have 90 and 130 as well. It's a hexagonal in cross section. A main difference you need to know is that the Kera ring is implanted closer to the central optic zone, 5 millimeter zone. The advantage is that it gives you a greater effect. So anything which is applied closer to the center of the cornea has a greater refractive effect. However, because it is also close to the central optic zone, in a mesopic pupil, it can lead to more glare and other photic phenomena as well. Now, as far as the planning and choosing the segment goes, there are four main considerations. One is the preoperative spherical equivalent. Then we look at the location of the cone, whether it's a centered or decentered cone, the magnitude of asymmetric astigmatism, there's the amount of IS asymmetry, and based on which we decide the number of rings, the thickness, and the arc length. So I'll quickly take you all through this. Now, the spherical equivalent in this table gives you a rough guide of the thickness of the ring which you need to use. INTAX is usually put in the 7 millimeter zone. You have INTAX SK, which stands for severe keratoconus, in the 6 millimeter zone. Nowadays, predominantly, we switched over to using the INTAX SK, and these are the corresponding thickness of the ring segment which you use as the spherical equivalent keeps rising. Now, location of the cone is important in deciding whether it's centered or decentered. So how do you know whether it's centered or decentered? So we look at the posterior float, and on the posterior float, if within the central 3 millimeter zone, that is 50% of the cone is within the central 3 millimeter zone, then it's centered. If greater than 50% of the cone is outside the central 3 millimeter zone, then it is a decentered cone. So let's look at this with a couple of examples. Now, why do we need to know it's centered or decentered? Because in centered, we use symmetric ring segments. That is, in this particular case, as you can see here, just one second, sorry. Yeah, so in centered, this thing, you use symmetric ring segments where the superior and inferior rings are of the similar thickness. In asymmetric, you use that is in decentered cones, you use asymmetric segments where the inferior segment is thicker and the superior segment is thinner. So first you have to also look at the incision where you need to place for before inserting the intacs. And this is based on the axis which you get either on refraction and along with it, you also have the axis which you get on the SIMK value. And then there are two other criteria which we follow. So either you draw a line which is passing through the center of the posterior float and the most elevated point on the posterior float, and you extend it on both sides. This will give you the flat axis, and the line perpendicular to that is the steep axis. Similarly, in pachymetry, from the center of the pachymetry map and through the thinnest point, you draw a line and extend it on both sides. That gives you the flat axis. The line perpendicular to that is your steep axis. So the incision is always placed on the steep axis. So the four values, that is after transposition, what you get on your refraction, on your SIMK, and the values which you get through the, like I mentioned, on the posterior float as well as pachymetry, should more or less correlate. And this will give you the incision location. Why is the incision location important? Because based on the incision location is how you're going to place the segments on either side of the incision, irrespective of whether it's a single ring or a double ring. Now, after identifying the cone, whether it's centered or decentered, if it's a central cone, we are looking more at the spherical component, like I mentioned earlier. So this is a cone where more than 3 millimeter more than 50% of the cone is within the central 3 millimeters. So we look at this, the spherical power after transposition. So here you have a spherical power of -8. And as you can see here, you go back to the table and you use symmetric because it's a central cone, and a spherical power is what you look into when you're looking at symmetric length segments, and somewhere of -8 to -10, use a segment of 450 microns. Greater than 10, you can even do 500 microns, but of course the peripheral thickness should also be a little higher. Now in this subsequent example, you can see that the cone is more decentered, more than 50% is outside the central 3 millimeter zone. When it is a decentered cone, after using the same steps for identifying the incision location, you then look at the cylindrical component in decentered cones. Now, the cylindrical component, even after transposition, as you all know, will not change. So in 3.5 is what is there in this particular case example. And you again go back to that table which I showed you earlier in asymmetric segments and a power of between 3 to 5 diopters of cylinder. As you can see here, the thicker segment goes inferiorly and the thinner segment goes superiorly. Essentially, the inferior segment goes towards the area where the cone is decentered. And obviously in keratoconus, in most often, the cone is decentered inferiorly. And therefore, the inferior thicker segment will go inferiorly and the superior segment will be thinner. Now, moving on to a little more about talking about single versus double ring. Now, a double ring, that is where two rings are placed symmetrically, there is a greater reduction, there is a global effect, and there's a greater reduction in the spherical equivalent. Where do we use a single ring? Now, essentially, if there is a very high ISA symmetry, essentially you want to just push the cone more towards the center. Then you can use a single inferior ring. And this is actually like as if there is no ring at all superiorly. We saw earlier examples in a decentered cone where a thicker ring is there inferiorly and a thinner ring superiorly. But when there is a very high ISA symmetry, you can just use a single ring inferiorly. Now, one thing we must understand in comparison to shorter segments, that is shorter arc length of 90 degree versus longer arc length, studies in animal studies have shown that as the arc length increases from 0 to 90 degree, there is a great increase in the amount of cylindrical reduction. That is, the action is along the axis of implantation. But whereas when you go beyond 90 degree, the effect is both on your axis as well as the spherical, on the opposite axis as well. So there is a greater reduction in the spherical equivalent when you go in for longer segments. So beyond 90 degree, yeah, I think I really need to rush up then. So higher superior inferior asymmetry, you have a single inferior segment. There are newer arc lengths which are available, 90 and 130 degree segments which are available. These, like I said, so wherever there is a higher astigmatism greater than myopia or astigmatism with hyperopia, like in this particular patient, you can use smaller arc segments which actually give a greater reduction in the overall cylindrical error without causing a great effect on the sphere. Because it's already a patient with some amount of hyperopia, if you also cause a flattening of the central cone globally, then the hyperopia will increase and thereby degrade the quality of vision. So this is the procedure itself, where you can see this is docking with a femtosecond laser after marking the apex of the cone. This is where the channel is created using the femtosecond laser and the incision is also created. We must say at this stage that mechanical way of making this pathway is also available. I have myself seen it only on animal eyes, and I have not seen it being done on human eyes. So it's largely given up, and we do it only using the femtosecond laser. Now, after that, you open up both the channels. Preferably, you open one channel at a time and insert one ring. And the ring is then inserted and placed 1 clock hour away, at least away from the incision. And then after that, the second channel is opened up and the second ring is inserted. And once the 2 rings are in place, you then remove the epithelium, which will be necessary for the cross-linking procedure. And then you place a suture at the very end of the procedure. So this is the end of the, you can combine it with cross-linking. Usually nowadays, we always combine intacs with cross-linking. You also have options to then subsequently rehabilitate them either with spectacles or contact lenses. The challenge with contact lenses is because you have a flatter center and a steeper mid-periphery. You can't use the standard contact lens. You'll have to go for a Rosque IC or a mini-scleral lenses. PRK can also be used if there is sufficient thickness to reduce the amount of residual refractive error. But what is more useful is a phakic intraocular lens, where if you have now centered the cone and the patient has a better best corrected visual acuity, after 6 to 12 months of stable refraction and topography, you can go ahead with a toric phakic intraocular lens. These intraop complications like segment decentration, false passage, perforation are more with the mechanical type of creating the channels. You don't seldom see it with femtosecond laser. But what you see are these post-op complications, especially if you've had segments placed too close to the incision, or if you had a loose suture. Now, the loose suture can abrade, cause epithelial breakdowns, and these are, again, keratoconic eyes who have a component of allergy as well often, and this can attract vessels. And these vessels can grow into the channel and can cause breakdown of the local tissue there. As you can see here, you can have a sterile necrosis, and then that subsequently causes extrusion of the segment. Rarely you can have infections which require removal of the segment and needs to be treated appropriately. You also have an innocuous complication like these deposits around the channel, which is quite common. Either lipid or calcium is what has been found out, and no real treatment is required for it. So in conclusion, this is the only device which is capable of shifting the cone from a peripheral to a more central location. Careful case selection and meticulous preoperative planning and with combination of different techniques can give you optimal results in most of these keratoconic patients. Thank you so much for your kind attention.
Thank you, Shreyesh, for an excellent talk. I had some questions for you, but your talk itself has answered it all. One question for Sharon. Sharon, are you there? Sharon, you are there? Yeah. Do you feel that cross-linking has still got a role to play when you're treating high refractive errors and you are wanting to use it to address regressions? Or do you use it only for borderline suspicious topography?
As of now, we use only for suspicious topography, not to treat a regression. But yes, there have been, I mean, we've seen literature there, and I'm sure everyone may have an experience on that. But we use it only for the, suspicious or those kind of cases.
Shreyas, you have anything to add on this?
On whether, I think extra procedures itself, I think after the advent of phakic intraocular lens, whenever we have even the slightest doubt, I think we are very comfortable using phakic intraocular lenses for all kinds of cases, even the lowest refractive errors. And that's an excellent option. Possibly just nowadays, at least my only thought for using an extra procedure is if you have a borderline pachymetry and you want to do a low myopic error and you don't want to push the patient for a phakic intraocular lens, that might be my only indication. But anywhere else where there is any ISC symmetry, anything a higher posterior float elevation, I think phakic intraocular lens is the way to go.
Is Partha there? I have just one question for Partha. Not there?
He is there. He's there. Partha is very much.
Partha, if it is a borderline cornea with low anterior chamber depth and a high refractive error, and you want to give a chance to the patient Would you plan to do it with GAG PI in these eyes in an extreme scenario?
Yeah.
Line AC depth?
Taking into account the angle is very important, even if the AC depth is just borderline. So even if it is borderline, the angle has to be assessed. If the angle is wide open up to the scleral spur you are able to see, then an ICL can definitely be implanted in such cases.
Anyone?
I have just one question, Chitra. Partha, if you can take this question.
Yes.
If there is the refractive error is not same in both the eyes, one eye it is low and the other eye it is high, and one eye allows examined laser to be done or smile to be done, would you change the procedures between the two eyes, or would you rather take a same procedure? And
the same procedure in both the eyes would be the option, unless the patient is keen to do a laser procedure. If it is laser contraindicated in one eye, and phakic IOL can be done in the eye in which the laser is contraindicated, both best be done the same procedure, unless the patient is totally convinced that it is a very low refractive error and can undergo a laser procedure.
Why should it be the same procedure? If it's a small refractive error in one eye, you could do a laser vision correction, no? For that?
So would you do a PRK in one eye and smile in the other eye, or a PRK in one eye and LASIK in the other eye, or LASIK in one eye and ICL in the fellow eye?
Yeah, it can be done, and we usually do it
We
also.
have been doing.
But if it is just a very small range between the two eyes, say -6 in one eye, in which laser vision correction is possible, and -8 in the other eye, in which it is not possible. So in such a case, both eyes best undergo the same procedure. However, it is just one in one eye, and laser vision correction very well possible can be mixed and matched.
But Chitra, can I just
Yes,
take a minute? If
yes.
it's allowed?
Yeah.
Ma'am, I think, no, I don't have a question. I just wanted to, whoever the fellows and PGs who are listening here, I think one of the most important take-home point from this session is there is nothing called as in the syllabus or out of syllabus. As when I was a PG, I used to listen to Chitra ma'am, Namrata ma'am. I'd come to AIMS as a PG student also. At that point of time, I'd never seen a keratoplasty, nor ma'am was talking about LASIK at that point of time, and she was talking about DSEK, and those were not even the words, and we didn't have a YouTube and other things. But what was important is it inspired people like me, and to see that one day I can do one of those procedures. I think at this platform for the PGs and everybody else, if it goes to a subconscious mind, there is something called what an intax is. Fantastic talk by Shreyas and people like Sahil, Shreyas, Pooja, Chaitra, all of them. See, all you need is it has to go to your subconscious mind that something like this exists. I'm sure let's be very clear, we cannot teach postgraduate answers in this platform. There are beautiful test books written by some of you. Namrata ma'am has written books. I'm sure reading is the best way to pass an exam. I think what you created, Dr. Chitra ma'am, is created a platform to inspire. And I think this is what I think Dr. Rupal ma'am mentioned. It is not possible to learn smile or intax or anything in this platform. See, in that way, I think, and congratulate the entire team, you, Dr. Anaga, and the entire team, to create a platform for inspiration. What I want to tell PGs, if you're not understood a single word of what Sahil said or Sean said or Pooja said, doesn't matter. But somewhere there, it remains in the subconscious mind. And I'm a proof of it that when I came back from where St. John's had sent to AIMS for some, and I came back and I thought, I know two words. There's something called DSEC, there's something called LASIK. And that is enough. And it was, and when we went back and checked the test book, there was no PubMed then at that point of time, which was good like this. There was nothing on test book. So all I say is that I'll just take a few seconds. Is that this kind of meetings I think is wonderfully well, and even though topics don't look like the question paper topics, I don't think PGs are very smart. If you look at every PG has their own portal I have two postgraduates in my own, fellows in my own hospital who have their very, very strong own portal for how to write an exam, and every question is written there. So I don't think they need us. But this platform, like even the last talk and Dr. Partha Biswa's talk, just inspires. I think has to be the take-home point, because these kind of meetings cannot be used for writing an exam, but to more of inspiration. I think Dr. Chitra and Pranaga has really given this beautifully to inspire. And I congratulate you. This was one of my first meetings as a moderator panelist in a postgraduate one. Thank you.
Thank you, Dr. Rohit. There was truly inspiring words, and of course, Namrata has also always been very encouraging for our ARC event. So, thanks a lot.
Chitra is very, very committed, very extremely committed.
I'm sure we have learned some more and gained a lot more clarity and lot of light on refractive surgery and its application. And this amazing webinar could not have been possible without the very positive energies of the expert panel, my amazing ARC team, and the excellent speakers. Every single speaker, I think I would create time to go back and hear their talks again, because they managed in that 10 minutes to give us so much concise information. Our special thanks to a very capable group of speakers, and of course, thanks to Kripal and his team of AIOS, Mr. Sunil, who's in charge of the webinar and is constantly being bothered by us because of time constraint and whole lot of issues. Sai and Manjula from Numotech, who have always been a support to ARC at all times. Of course, my terrific, strong ARC team and my charming co-moderator, Anagha. Our gratitude to Entod and Mr. Nikhil, who remains engraved in our minds for sponsoring all our activities, and each and every one of you, dear friends in these attendees, for making it such a remembered evening. Thank you, one and all of you. Thanks so much. Thanks, Pooja.
Thank you.
Thanks, Mr. Rohit. Partha, you were really good. Thanks, Rishad. Very good talk. You made that microkeratome talk so scientific and good.
Thank you, ma'am. Thank
you.
Yeah.
Good.
A really nice session.
Better, Chitra. You could pick on the youngsters. They were phenomenal.
Phenomenal, yeah. Sean, you were also very good. Everybody was
All of
so
them,
good.
I think, all the lectures.
I think we need to thank Dr. Mahipal sir, President AIOS, for what do you say, enlightening us that this webinar module can be there here to stay, and for being so liberal in giving this webinar model to us, in allowing us to do it, and for not only do it at the headquarter, but across all across all wings. So thank you, sir.
No, always welcome. Sorry for being late, because I have to make my centers run. So sorry I was late, but anyway.
So thank you, sir. Your contribution is really great as far as AIOS goes.
Yeah, I do hope the next 2 years continue in the same fashion with so much encouragement we got from our president.
Not virtual.
Not virtual, physical.
Yeah, there's no substitute for meeting. Really.
No puppy chappi and no drinks and no dances and nothing. Huh?
No pulling of legs.
No jokes. You have to be very, very sedate and moderate when you are on webinar.
Be serious.
Serious.